correction with both medial and lateral menisci repair. So, we'll go ahead with the talks. I would like to invite Dr. Sridhar sir, to moderate the session. Dr. Ramraj Garu, sir, and Dr. Sharat Sharma. I request all the faculty to stick on to the time, because as we are running a bit short of time. First talk by Dr. Raj Babu, Anatomy and Biomechanics of Meniscus.
Recording stopped.
Good morning everyone. I am Dr. Raj Babu. Today I will discuss about anatomy and biomechanics of meniscus. We will discuss about anatomy of meniscus, vascular supply, neuroanatomy, microanatomy and composition, meniscal motion and biomechanical roles of meniscus. Meniscus will appear between 8th and 10th week of fetal development. The meniscus is most vascular and cellular during fetal life, prenatal meniscus compared to postnatal, and from 1 to 3rd year of life, this collagen content is increased and cellularity and vascularity will decrease. So the meniscus is a crescent-shaped fibrocartilaginous wedges between the femoral and tibial condyles. So this is critical for low transmission, shock absorption, joint stability and congruity and joint lubrication and for nutrition. So medial meniscus is a semilunar structure with less mobile and more prone to injury. This is the schematic representation of medial meniscus. It is the width of the medial meniscus is more posteriorly compared to anterior, and the thickness is same, and the medial meniscus is divided into 6 zones: anterior root, and which is attached to the anterior root attachment is anterior to the apex of the medial tibial spine, anterior tibial spine, and anterior zone, which is divided into zone 2A and 2B by transverse ligament, and this is posterior medial zone. So this medial zone is very close to the medial collateral ligament, posterior zone and posterior root. The attachment of posterior root is 9 mm posterior and 0.8 mm lateral to the medial tibial eminence. Coming to lateral meniscus, this lateral meniscus is circular structure with lateral meniscus is circular structure which is more mobile and loosely attached. This is the lateral meniscus structure. This is 3.5 mm in length, and this also divided into 6 zones: anterior root, anterior zone, and popliteal hiatus, and posterior horn and posterior root. These are the meniscofemoral ligaments. There are 2 meniscofemoral ligaments: anterior meniscofemoral ligament called Humphreys and posterior meniscofemoral ligament called Viscerus. So this is meniscofibular ligament, that number 1. The vascular supply, meniscus is usually less vascular. The vascular supply for meniscus arises from the superior and inferior branches from medial and lateral genicular arteries. The peripheral zone of the meniscus is penetrated 10 to 30% of the medial meniscus, and the lateral meniscus 10 to 25% of the peripheral zone. That is called red zone. And the avascular zone, inner 65 to 75% of the meniscus is less vascular and relies on synovial fluid for nutrition. Neuroanatomy, several different types of neurological receptors identified within the meniscus tissue. The nerve supply for meniscus arises from the posterior articular branch of posterior tibial nerve and terminal branch of obturator nerve and terminal branches of femoral nerve, and recurrent peroneal branch from common peroneal nerve which supplies the lateral capsule. And there are these nerve fibers are mainly concentrated in the peripheral portion and lateral horns of the meniscus. These are implicated in the proprioceptive function, and some freestanding nerve fibers are present in meniscus which are useful for the slow pain conduction. Microanatomy, usually the meniscus is a fibrocartilaginous tissue with collagen and fibrochondrocytes and fibroblasts and chondrocytes. So there are two types of cells, fusiform cells which are superficial and ovoid cells. These cells form the extracellular matrix. Usually meniscus is composed of 75% of the water and remaining dry organic matrix, which is mostly composed of type 1 collagen. This type 2 collagen is present in hyaline cartilage. So these collagen fibers are arranged in different orientation. Deeper fibers are circumferentially oriented, and superficial it is oriented in radial direction. So compared to hyaline cartilage, the proteoglycans are less compared to in meniscus. This is the schematic representation of fibers arrangement. So meniscal motion, meniscus moves during the knee flexion from 0 to 120 degrees. There is medial excursion of 5 mm and lateral excursion of 11 mm. That's why lateral meniscus is more mobile. This is the MRI image, shows the motion of the meniscus from 0 to 120 degrees. So the biomechanical roles of the meniscus is load transmission, shock absorption, and joint stability and congruity, and joint lubrication. So in total meniscectomy patients, the joint stress is increased to 23%. The current trend is to preserve the meniscus whenever possible. Meniscus are essential for knee joint and understanding the injury management. Future research on focus on healing and replacement of the meniscus. Thank you.
Thank you, Dr. Raj Babu. So, thank you. Maybe one question. So, anatomy is only related to why the medial meniscus are more prone for tears compared to the
Because
lateral
it
meniscus.
is less mobile.
Less mobile. So that's the keynote of the our talk now, because based on the anatomy, why we get 2/3 of our meniscal tears are only on the medial side. Yeah, thank you so much. So as Pratmesh sir has to go for a next live surgery, so we'll have how I do my ramp lesion repair by Dr. Pratmesh Jain. Yes, sir.
Thanks a lot. Thanks a lot. It's very nice to be here in Vizag, and we'll just be focusing on meniscus ramp lesions and how to repair it. So basically, it's a longitudinal, vertical, or oblique peripheral tear which is affecting the posterior horn of the medial meniscus, and this leads to a meniscocapsular or meniscotibial disruption. And this is in the setting of a ACL tear. So approximately, it's a very common injury, and you need to do a specific trans-notch approach to actually identify the ramp. So if you see this is a very important talk. Working? This is working? Huh? Not working? No pointer. Okay. So if you see this this picture, this is a very important picture. So what includes the ramp? That is very, very important. So what is important is pointer. Okay. Now you can see. Okay, that's okay. So if you see this, my cursor, what makes ramp? It is very important. So the red region is the red zone of the meniscus. Then you have a meniscocapsular ligament which goes from the meniscus to the top, and then you have a meniscotibial ligament which goes from the meniscus down. So ramp lesion is a complex lesion in which you can have an injury either in the peripheral meniscus, you can have injury in the meniscocapsular ligament or the meniscotibial ligament. Which one? This one? So you can have an injury in the meniscocapsular ligament, or you can have an injury in the meniscotibial ligament, or you have an injury in the peripheral part of the meniscus. So all of these can cause injuries to the ramp, and there is a classification which actually separates the different kind of a ramp lesion. We'll just quickly go on to that, and then we'll be proceeding for the surgical techniques. Now, risk factors for ramp lesions are important. So if you have a bone contusion on the posterior medial tibial plateau, that is a very high risk that the patient may have a ramp lesion. You have a chronic ACL injury, you have a steeper slope, and a varus in the knee more than 3 degrees. So these are all the risk factors in which you have a higher chances of the ramp lesion. Now, as I told you, this is the region of the ramp. You can have an injury here, you can have an injury here, and injury here. So the type 1 is basically the meniscocapsular, the upper one that is torn, that is called as a meniscocapsular ligament tear. This is how it looks. Type 2 is basically in the partial peripheral meniscus, and that is in the superior part. So this is how it looks. Now you have a partial inferior. You can have it here, that is type 3A, or you can have here, that is the meniscotibial ligament. So that is type 3A, then you have a type 3B. It can extending it into the meniscotibial ligament, and this is how it looks on the MRI. So you can have sort of different combinations and permutations, and type 4 ramp is actually a complete ramp. So it's a peripheral posterior horn medial tear like this, and this is type 3B, this is type 4A, and then you have, this is a type 4B, which is from down to up completely, and type 5 is a double level of the ramp. So this is how it looks. So basically a lot of classification, but the most important thing as far as the treatment is concerned, you have 2 to 3 different types how you can treat a ramp. So this is a standard technique. So if you have a type 1A or a 2 ramp and it is up, so you can go into the trans notch view, that is also called as a Gilchrist view. You go on the back of the knee, you identify, so you can see that there is a red region here, so that shows the bleeding. So you probe it out, you identify where the tear is, and then you can use your all inside repair devices to repair this sort of a ramp lesion. So what you need to do is you need to put your device at its proper place from the top and then to the meniscus. So one on the capsular side, one on the meniscus side, and you repair it directly. So this is how you put it. So you put it through the tissue, make one panel. So one important thing that you can do is occasionally this ramp will fall down. So if you can make a posterior medial portal, you can lift that area and you can try to lift the sloppy portion of the capsule down, or you can reverse your needle to put it into the good part of the meniscus, and then you just repair it onto its place. So what that will do is that will close down the ramp lesion. So you can do it for the stable patterns, type 1, type 2 maybe. So that is the best technique. So same thing if there is a type 3, that means that is the inferior surface, you can elevate the meniscus and do it from the inferior side. So this is the most standard and easy way to treat a stable small ramp, type 1, type 2 predominantly. Okay. So this is how it is repaired by using a all inside meniscus repair device. So this is the first technique. The second technique that we do is a posterior portal techniques. So what we do here is, in this technique, if you see there is a large ramp. So you have a ramp which is extending from the posterior and it is extending onto the medial side. The other important thing is whenever there is a ramp, it tends to fall down, just like your Bankart. You see when there is a ellipsa lesion, you elevate it. So same like this, the ramp, the posterior part of the ramp tends to fall down and you need to elevate it to repair it. So what here we are doing is we are making two portals, two posteromedial portals, one high posteromedial portal and one low posteromedial portal. And then we will be using the ideal suture shuttle devices to pass our threads and repair the ramp sequentially. So there are two techniques into that also. So you can do it either viewing from the Gilchrist portal in the front, or you can view from the top and then repair it. So it is up to you, whatever technique you want to wish. But the most important thing is you need to elevate the posterior portion of the meniscocapsular junction, take it through the meniscus, and then you have to repair it accordingly. So you need to basically use it with three portals, two posteromedial and one Gilchrist. And you can use one portal for the knot tying and closure, and then you pass it, you shuttle relay a small suture, and then you can tie both of them into its place, thereby leading to its technique. So the other thing that you can do is if you want to place multiple sutures, you can do what is called as a pass and park technique. So you pass multiple sutures and tie them in the end. So that is also one technique that you can do if you have a very large sort of a ramp lesion. Now the third thing that I am doing recently is doing something with the Eco Stitch. Now Eco Stitch is a new device. It's basically all inside devices loaded on the needle. So the earlier surgery we saw the inside out technique. Now this technique is basically a needle loaded anchors. So what we do is we pass the needles separately, and both of these needles, the set comes with two needles. Both of these needles are loaded with one anchor. So one by one, both the anchors are passed on the posterior part, and then we tie it intraoperatively. So there is no need to make any incision on the posterior medial aspect, and you can do a very, very good sort of a repair of the meniscus and the ramp. So if you are doing a ramp tear with this technique, you need to swap your portals. You visualize with the middle portal and work on the lateral portal, and then you can use this device to actually close the posteromedial capsular junction, and you can close it in a nice way by using this technique sequentially. You need to use one or two half hitches to secure it. And this gives an advantage that we don't have to make any posteromedial incision, so there is a very less chances of any neuropraxia as such. So very good technique, two anchors both loaded on the needle, and you can repair all sorts of complex tears and complex ramp lesions along with use of this technique. So basically you can use an all inside device for stable lesions, you can use two posteromedial portals and then closing with the second technique, and the third technique you can use Eco Stitch technique for the ramp repair. Thank you.
Thank you, sir. How often do you see the ramp lesions, sir?
So it's a very, very good question. So if ramp lesion is one of the most common missed pathology or missed etiology, they say, but usually contrary to the literature, I do see it more commonly in acute tears, and I do feel that some of it may heal in chronicity. But I'll put it around 20 to 25% of my ACL tears, I would see a definite ramp lesion. So definitely you have to look, suspect on the MRI, and then you have to confirm on your notch view, the Gilchrist view, you have to go on the posterior medial corner and just look into it, specifically posterior. And then there is a needle test. If sometimes you don't see it properly, you can use a needle to elevate it to actually visualize the lesion correctly.
A needle from the posteromedial portal.
From the posteromedial portal. For a needle test, you don't need to make a portal. You just put a needle
and
elevate it. But if you find there is a ramp lesion, you make a formal portals, two portals or one portal, whatever it is, and then do the repair.
Do you augment your repair any ramp? If it's isolated ramp lesion, do you augment it, any biological augmentation?
Usually not, because the ramp is on the peripheral side, so it's a very good vascular, almost it is on the red zone. So it's ramp lesion usually heals well. Healing is usually not a problem. I usually don't modify my rehab also if I do it with the ACL. You can do it with the rapid rehab as well. It doesn't matter.
If it's a chronic ramp, it's better maybe posteromedial with suture lasso. You can take a good amount of tissue rather than the all inside.
Yes. So all inside is for the stable part, 1 and 2, and then For rest of them, the unstable part and chronic ones, it is better to make
Yeah.
two portals posteriorly.
Thank you, sir. Thank you, sir. Thank you so much.
Thank you.
Excuse me, sir. Sir, maybe a naive question, but do all ramp lesions need surgery or do they go for conservative treatment?
So as I told you, the classification wise, some people are of the argument that type 1, some of it you may leave. So if it is a meniscocapsular junction only and that's on the superior part, some of it may heals down. So you can leave those things. Rest of the ramp lesions usually you should repair. So, and if you don't repair them, you will have a higher chances of late laxities and you may have a post-operatively increased anterior translation. So, it's better to repair most of your ramp lesions apart from the type 1, if you may consider that.
Usually type 1, 1 and 2, some lesions in chronic, we see they would have healed or
Yes,
with some
or
lax
yes,
capsule.
Yes. So that occasionally you may leave it, but most of the times I would recommend and promote all of you here to repair more and more of these. So if you see it and if it is evident, you repair it. So chronicity will not affect my judgment. So if I see a ramp lesion, it's there, it's better to go in and repair it. So I would usually put them in a brace, most of my ACLs in a brace, and I usually keep the brace for about 3 to 4 weeks, and I mobilize within 5 to 7 days. So that is what I do for my normal ramps also. Yeah, you can start weight bearing at about 5 to 7 days in ramps. Thank you.
Thank you, sir. Thank you so much. So we'll go ahead with the next talk. By Dr. Manoj. Dr. Manoj is a radiologist in KIMS Hospital. So he will be enlightening us on what to look for the knee MRI and how to read a knee MRI. So welcome, sir.
Good morning, everyone. I'm Dr. Manoj. I'll be dealing with a concise overview of the meniscal lesions. Since we know the normal anatomy well, I'll be beginning with the MRI anatomy. So this is the medial side of the medial side of the knee because this is the tibia. So this is the body of the medial meniscus. So this body is seen only on two adjacent slices, 1 and 2, and that is it. So then we enter into the anterior horn and the posterior horn. The posterior horn of the medial meniscus is larger than the anterior one. And these are the roots. The anterior root has a variable attachment over the tibia. But the important thing is that the posterior root has to be visible when the PCL appears into the frame. So going more laterally, this is the ACL. And then as soon as we go laterally, we can see the anterior and the posterior roots of the lateral meniscus. Then these are the horns, and unlike the medial meniscus, these are of relatively same sizes. And this is the body of the lateral meniscus again, which is seen only on two slices, 1 and 2. So how does a meniscus look on normal MRI? It is uniformly hypointense on all the conventional sequences that we do. It is low because of it has tightly bound collagen and the lack of mobile protons. So that is why when there are tears and degeneration, we look for the presence of water molecules. So proton density, FATSAT, STIR and T1 images are useful for it. T2 images, so even though we do it very commonly, they are not very useful for detecting MRI tears on the MRI. But T2 star again is very sensitive, especially for small joints. So now we begin with the pathologies. Starting with meniscal degeneration, we grade them into grade 1, 2 and 3. Grade 1 is a small focal hyperintensity which is not extending to any articular surface. Grade 2 is a linear hyperintensity which also does not extend to any articular surface essentially, but it is also subdivided into A, B and C types. Grade 3 is an abnormal signal intensity that extends to at least one articular surface on more than one consecutive image and is a definite tear. So this is an image. This is an image showing a focal altered signal intensity in the posterior horn of medial meniscus, and that would be a grade 1 degeneration. This one is a linear hyperintensity. So this, and is again not reaching to a articular surface. So this would be a grade 2A. This slide shows meniscal tear classification. I will not be reading out. Instead, we will go through them in detail. First, we look at the image. So that is a linear hyperintense signal intensity in the posterior horn of medial meniscus that is paralleling the tibial plateau and is dividing the meniscus into superior and inferior parts, and hence it is a horizontal tear. They are more common in older individuals, and they are associated with parameniscal cysts. So this is again a linear hyperintensity, but this time it is perpendicular to the tibial plateau and is dividing the meniscus into medial and lateral parts. So this is a longitudinal tear. There are two variants of this, Risberg tear and a ramp lesion. Risberg occurs at the junction of the attachment of Risberg to the posterior horn of lateral meniscus. They are associated with ACL tears, as we can see on this image. So this hypointensity behind the PCL is the Risberg ligament, and as we go towards its attachment, we can see that the cleft seems to be extending way beyond its expected attachment site. So it is postulated that the normal attachment site of the Risberg is approximately 14 mm from the lateral border of the PCL. So if it extends beyond that, we can suspect it's a Risberg tear, especially if there is an accompanying ACL tear. So ramp lesion are vertical longitudinal tears at the posteromedial junction of the meniscocapsular junction of the medial meniscus. They are also associated with tears, so ACL tears, sorry. There are two classifications for ramp lesions, but first we'll go through the anatomy. This hypointensity is the meniscocapsular ligament. This is the posterior capsule. This intermediate signal intensity is the meniscocapsular attachment, and the hypointensity is the meniscotibial ligament. So in this first image, we can see the arrow is pointing towards a meniscocapsular disruption. And in the second image, there is a partial peripheral tear of the posterior horn of the medial meniscus, but is only at the femoral end. On this image, we can see the same thing, a partial peripheral tear, but is again, it is at the tibial surface. In the next image, the same is there, but there is also a meniscotibial ligament injury. This is a complete tear extending from the femoral to the tibial surface. And in that, the image, we can see that the intermediate signal intensity is replaced by hyperintense signal. So that is a meniscocapsular disruption. And the final, this one is a double vertical longitudinal tear of the posterior horn of medial meniscus. So radial tears are perpendicular, vertical tears that are perpendicular to the free edge of the meniscus and the tibial plateau, and they are divided into classical and classical radial and root tears. In the classical tears are commonly associated with horizontal tears in lateral meniscus, and they are associated with flap tears in the medial meniscus. These are also associated with meniscal extrusion. First, we will look through the sagittal images. So here we see a tear at the free edge, which is extending towards the periphery. So this is a marching cleft sign. And if we get a coronal slice that passes exactly through this, we get something called as a ghost meniscus. And in an axial section also, we can see a full thickness, complete radial tear. In this axial section, we can see that there is a radial tear which has an oblique orientation. So on these SAG images, we can see the same thing. The hyperintensity is extending towards the periphery, towards the free edge, sorry, and is having a slightly oblique orientation. And because of this oblique orientation in a parabolic tear, we will not get a ghost meniscus sign. So bucket handle tear, it's a displaced vertical meniscal tear where the displaced part, where the meniscal fragment is displaced centrally. They are common in the medial meniscus, and they are also associated with ACL tears. we can see here that there is a complex tear of the posterior horn of the medial meniscus, and anteriorly there is a meniscal fragment that is arising from the anterior horn, and this fragment is going into the center of the joint and giving us a double PCL sign. So the same thing can be seen on the coronal images, where this fragment is going and is under the PCL, and we can also see that there is a complete full thickness ACL tear. Flap tears are also basically displaced horizontal or oblique tears. We can see on the coronal images that the medial meniscus is truncated, and there is a small meniscal fragment that is displaced into the superior parameniscal recess. So this is a flap tear. These are also more common in the medial meniscus, and like the horizontal tears, they are associated with parameniscal cysts. So meniscal roots are most common in the posterior roots. Root tears are common in the posterior roots. So in this image, we can see that in front of the anterior to the PCL, there is no root is not visible here. And even on the coronal image also, we cannot see the meniscal root completely. So this is a posterior root tear of the medial meniscus. They are also associated with meniscal extrusions, secondary osteoarthritis, and subchondral insufficiency. For reference, this is how a normal root would look like. So discoid meniscus, they are diagnosed when the meniscal body width is more than 15 mm on coronal sections, or there is one more method where we can measure the minimum tibial width and divide it by the maximal tibial plateau width, and if it is more than 20%, we call it a discoid meniscus. On SAG images, the meniscus is visualized on more than 2 sections. If the coverage of the meniscus is more than 80%, it is complete discoid, and if it is less than 80%, it is incomplete discoid. So we should be aware of some pitfalls to avoid overcalling and prevent any misinterpretation. So this is a meniscal flounce where the contour is wavy, and hence this might simulate a radial tear in some cases. This is a pseudo-radial tear, which is a normal variant. The meniscus looks like that is truncated here, and it is generally located at the junction of the anterior horn and the medial meniscus. So that the image there looks like it is normal, but on T1 we can see that there is a meniscal ossicle. So it is important that we look at all the sequences, and a prior X-ray is also helpful. So some ligaments that attach to the menisci can also mimic tear. These include anterior intermeniscal ligament, ligament of Humphrey and Risberg. At the section just before the attachments, physiological fluid between these structures can appear as a tear. But if we can scroll through the entire image, we can see that they are the normal ligaments. And finally, the meniscopopliteal ligaments, in combination with the meniscus and the popliteal ligament, when seen with this intermediate soft tissue, can simulate a vertical tear. Thank you for your attention.
Thank you, Dr. Manoj, for the wonderful presentation of how to look for the meniscal tears in the MRI. Any doubts from the audience?
Dr. Manoj, maybe one basic question, like how early do you want us to take an MRI in case of any ACL or meniscal tears? So what is the ideal time? 3 weeks, 6 weeks?
Yeah, I think we should wait a bit. I think 2-3 weeks would be better, because in a trauma case there's so much edema that it will be hard to tell whether it's just a contusion or there is actually tear there. So we do have a difficulty reporting when there is a trauma the previous day and we get an MRI. We have a difficulty in telling what it is. And if it comes 2 weeks later, we see there is a lot of discrepancy in our reports itself.
Exactly.
So it will be better if we can wait for some time.
So usually 3 weeks is a comfortable time for you to pick up the lesions?
If you need to do it, then you have no choice. But I think 2 or 3 weeks would be sufficient.
No, from the radiologist perspective,
2-3 weeks.
2-3 weeks is an ideal time. Okay, right. Thank you. Thank you so much.
Thanks.
Thank you, Dr. Manoj. Now, this is the beginning of the second session, the cracks in the crescent. I would like to invite Dr. Praveen Mopada for his next talk. on traumatic tears of meniscus, the types and significance. Dr. Praveen.
My topic is traumatic meniscal tears. Traumatic meniscal tears, by definition, it is associated with sudden onset of injury or any sustained injury of the knee, and more commonly that degenerative tears are not considered as recently not considered as meniscal tears. It is called as meniscal lesions. Okay, traumatic tears. Mostly vertical tears like longitudinal tears, radial tears and flap tears, and root tears, mainly posterolateral root tears are involved. Approximately 6% of the acute knee injuries knee injuries patients have meniscal tears. Most of the time 75% of the meniscal tears are medial meniscal tears. In 15% of the athletes acute knee trauma and hemoarthrosis sustain isolated meniscal tears with a higher side of the medial meniscus tears than lateral meniscal tears. Meniscal tears mainly two types, stable and unstable. And unstable tears mostly on the central part of the meniscus can be involved, and which is dislocated into that joint space, and with probe it can be displaced by at least 5 mm of the distance. Radial tears generally will define as an unstable tears. Stable tears which is not displaceable, and generally mostly clinical tests mainly we are using McMurray's and joint line tenderness for diagnosing the meniscal tears. Already sir told about that MRI regarding meniscal tears. Most of the accuracy of the MRI for detection of that traumatic meniscal tears around 88%. Classification based on the MRI is around type 1, type 2, type 3 already described by the previous speaker. In type 3 most of the times we are getting complete tears, which is traumatic tear which extends into that articular surface. And regularly we are classified these traumatic tears based on that blood circulation and zone of the meniscus, which is red zone and white zone and white zone. Most red zone are tears have better prognosis. Depends on that configuration. There's meniscal tears mostly in radial tears, longitudinal tears, flap tears, horizontal tears, and complex tears. What is the significance of these traumatic meniscal tears? Mostly when we are not treated these traumatic meniscal tears, it leads to the degeneration and which causes that osteoarthritis in radial tears and flap tears, which might get more degeneration. In longitudinal tears, that tear which is extends and which got that tear fragment into that joint line, which causes the locking and degeneration of the joint. radial tears, which are most often symptomatic tears, which gives the pain and clinking side, and which extends when it was not treated, it converts into that bucket handle tears. During ACL reconstruction and lateral meniscus, we can leave this with a small radial tears, which generally gets good healing. These repair techniques will be discussed by the Rajshekhar sir next. Horizontal tears, these are like mostly in stable tears, and we can preserve the most of the meniscus possibly, and without resecting the maximum meniscus. Will only resecting the unstable fragment, and will repair the most of the complete meniscus. These horizontal tears generally associated with that meniscal cyst, and when we have a meniscal cyst, we should debride and empty the cyst, and then we should repair the horizontal tear. Peripheral and longitudinal tears, which are extending a very minor tear to complete bucket handle tears. Generally, we should try to reduce the these tears, and when we reduce this, we should get the maximum repairable tissue. So finally, meniscal root tears, which should repair aggressively during these meniscal traumatic tears. These techniques should be in either simple stitches or with button or trans bony technique. We can use this fixing the meniscal root technique. Meniscectomy we generally avoid during traumatic tears, because it is an acute tears. We should repair how much we can possible. The very rare indications when meniscectomy indicated in that traumatic tears, which is in a vascular zone, and it is not reducible, and which is a more complex tear, and which is meniscus is badly damaged, and patient demand is low. Yeah, thank you.
Thank you, Praveen. So we invite Dr. Rajshekhar to talk on his techniques of traumatic tear repairs.
So happy to have another course in Vizag. Last bench. Thank you. So meniscus, this is the overview. So why meniscal repair? We have seen a lot of types of meniscal tears, and earlier it used to be meniscectomy, removal of the unstable flap or whatever flap it was coming into the joint, or when it is creating problems, or it is used to be removed. But now the importance of meniscal repair has come up because there are a lot of functions which the meniscus performs. Like it carries almost 50 to 70% of the load of the compartment, and it is associated in acute conditions with ACL tears, which are repairable. The functions are the load transmission, stability, lubrication, and proprioception and shock absorption. And it is proven beyond doubt that meniscectomy leads to increased peak contact pressures on the articular cartilage, leading to osteoarthritis. And the other important thing is even the amount of removed meniscus is directly proportional to the development of osteoarthritis, increasing the pressures. You can see that when we remove almost 50% of the meniscus, there is a peak increase in the contact pressures, leading to development of osteoarthritis. So not just meniscal repair, we should try to preserve as much meniscus substance as possible to avoid these things. Now, the common perception of predictors of meniscal repair are like this. Whenever we see a meniscal repair, we feel that should this be repaired, should this not be repaired, will this give a good outcome or not? In that, the first thing is zone of tear. This zone of tear is based on the meniscal vascularity, which is described by Ornosky. It goes from the peripheral area into the meniscus. So based on that, the zones are divided as the peripheral zone is red zone, this is red-white zone, and the white zone. The white zone has less vascularity and the potential of healing is less when compared to the red zone. So the red zone heals better. And the types of tears, as already mentioned, the longitudinal tear, which might get into bucket handle tear, and the radial tear, which is across, root tears, oblique tears, the horizontal tears. The important thing is that the fibers are circumferential in nature. So whenever the tear extends like this, this is a bad tear to repair because it goes across the fibers and creates, the repair is not that good. And this is how it is said that in the second lick evaluation of repaired medial meniscus, the simple longitudinal tear and bucket handle tears heals better. So because of the tear pattern. And when we take age into consideration, there is no difference between people who are younger than 40 or older than 40 when repaired. Only the type of tear, the zone of tear matters. So when the type of tear is simple and the zone of tear is in the red, it heals better. And regarding the chronicity, even when the tears are 3 months, as Dr. Pradmesh sir was saying, chronicity doesn't matter. If we repair it after proper enhancement of healing techniques and we repair it, it heals well. So with this background, the right patient for meniscal repair will be an acute traumatic tear, which is in the red zone and is a simple longitudinal tear. With the age and chronicity of the tear doesn't have any impact. And to all the techniques, basics are common. We should give a solid primary fixation, and there should be some biological process which will enhance the healing. It might be a physical method like a prior abrasion of the surfaces to enhance healing, or addition of biologics to aid in healing. We'll see what are those. So the suturing principles are also common for both of them, for everything. One is the suturing patterns. This is the vertical suture, which is called vertical mattress, one over the meniscus and one over the capsule. This is the strongest because it is perpendicular to the fibers. As I said, the fibers are circumferential. So one that is perpendicular to the fibers, the vertical is strongest, then comes the oblique, and then comes the horizontal mattress. This can be altered depending on the tear pattern. And this is how we do the outside and repair. One goes through the capsule, the other goes through the meniscus pattern, and we pull it and we get the tear right. And yeah, coming to the techniques to enhance healing, as I said, there are physical methods and biological methods. Of these, the common things are, the common things are, one is rasping. This is how we rasp both the surfaces. The other thing is vascular access channels. We take a microfracture awl or needles and we poke small holes in the synovial to let the blood supply come in. And notch microfracture, when the ACL is not done, when it is not associated with the ACL or something, then we can do a microfracture to let the factors come in. This is fibrin clot. In horizontal tears, we can put it like this and give a suture. So, yeah. So this is a bucket handle tear. I'll just show the techniques of the enhancing. Now, when you look at the bucket handle tear, it is almost at the red zone. So when you displace it into the notch, you can see what zone it is, and then you can do all the physical methods of enhancement. Go with the rasping both on the synovial side and also the meniscal side, and you can do the vascular channels with the microfracture awl. Positioning you can do with either leg hanging or a table with leg support. Portals are basically anterolateral and anteromedial, depending on the approach point to the meniscus and under tourniquet control. So, relevant anatomy, the anatomy is important because on the posterior aspect of the lateral meniscus, medial meniscus, there are not much of the neurovascular structure except for the saphenous nerve. But on the lateral side, you see this is the popliteus tendon, and this is the common peroneal nerve, and this is the popliteal artery. So when anything beyond the peroneal tendon, the popliteus tendon, there is huge risk of the neurovascular injury. So this is the direction. So when we go from the medial portal, it almost hits the peroneal nerve, and when we go from the lateral portal, from the root area beyond the peroneal, the popliteus tendon, it goes towards the vessels. So based on this, there is a study which says that the medial and transpatellar portals, using all inside devices, can prevent the neurovascular injury on the posterior neurovascular bundle. And regarding the, there is one more study which says that when we try to repair near the PCL, a more lateral portal is better. When we go 3 centimeters, 3 mm beyond from the PCL, then repair from the medial portal is better. But normally the other outside in repairs, the inside out repairs, all we usually go through the opposite portal. That is anterolateral portal for the medial meniscus, and anteromedial portal for the lateral meniscus, that sir has shown in the morning. So based on the neurovascular bundles which are posterior, they have decided the things. This is the anterior horn, which is amenable to outside in techniques. We can go like this and take it. The inside out, the expansions have increased because of the cannulas, the instrumentation which has come up. Earlier it was only till here we could use the inside out, but with the cannulas and all, we are going till here. But on the lateral side, if you see the popliteal tendon, beyond the popliteal tendon is always all inside. And coming to the outside in technique, as I said, this is it to the anterior horn. Up to the body, we can use this. There are specific instrumentation like this which can be used, or a simple 18 gauge cannula will also do. So this is how we do it. This is outside in technique. We introduce the cannula first. We support it with the probe as a counter, and we introduce the needle like this, and the second needle goes into this. Try to go a little in triangular fashion towards the other one, so that you can pull the loop into it. If you go parallel, the loop, pulling out the loop is quite difficult. So go a little towards that in a triangular fashion, and then one loop comes out of the first needle. The second needle goes into the loop like this, and then the thread comes out from the second needle. The thread comes out from the second needle, and that is, the thread is pulled through the loop. So you can keep, this is the Prolene that we have used. You can keep Prolene, or you can change it to the non-absorbable sutures also. So that's how the loop comes. And then inside out meniscal repair is the most commonly used technique. It covers most of the meniscal area. But the important thing is you need to know the safety incisions, you need to know the pie crusting techniques, so that you don't injure the cartilage. As I was saying before, meniscus heals, but cartilage doesn't heal. So to avoid scuffing to the cartilage, always this is important. So even in results also, inside out meniscal repair gives better results when compared to other things because of the technique. Earlier, this used to be the instrumentation set before, where we used to have all the types of cannulas, two lumen cannula, curved cannulas and all that. But now with the advent of the zone-specific cannulas, so this is one cannula where this is the zone navigator system, this is cannula. You can rotate it all 360 degrees. Now you can go to the anterior horn, you can go to the middle horn, then you can even go to the posterior horn with the zone-specific cannulas. Now even we have the third generation one, which is like you don't need the other person also. You can just put this, and by giving the pressure here, I mean, when you can shoot the needle out, it just comes out and takes the bite. You can load the needle again and do it. So this is a reusable one. So this is what happens in the outside in inside out meniscal repair. You put the cannula out there like that on both sides of the tear. This is a 2 lumen cannula, double lumen cannula, which you go through it. Then you give the needles in. The needles, as there are two types. There are either you can have a preloaded needles, like they come in set, 2 needles together, or you can have a reusable needles also, where you can load the threads again. You can use it again. So that's how we put the posterior spoon to avoid injury to the neurovascular bundle. the needles touch there and get deflected outside through the safety incision. And you pull the needles, and along with it the thread comes out. Yeah, as you can see, the thread comes out. The cannula should be kept till you see the thread inside, because to avoid strangulation of the thread in the fat pad. So these are the safety incisions. We have one in the lateral side or on the medial side. So this is the semimembranosus. This is the gastrocnemius. So this is the MCL. So posterior to the MCL, we retract. First we go like this. I have a video, but okay. So this 2 to 3 centimeters incision is given here, and then you incise the sartorius fascia, and then you see the MCL, and pull the semimembranosus down and go there between the capsule and the gastrocnemius. So this is a video, but so that's how the landmarks. You take the adductor, tubercle, and posterior tibia. You give 1/3 over the joint line and 2/3 below the joint line, so that distal to the joint line you can pull it easier. So that's how you separate the sartorius fascia, and then behind that you separate you pull out the gastrocnemius from the capsule, and then that's how you put a spoon there in that point. The triangle area is the point where you should go and pull the sutures out. And in the same way, we have safety incision on the lateral side also, where we go through the IT band. That is how you mark it, and then you give an incision, the posterolateral approach. You incise the IT band, push the IT band and the biceps below, so that you don't have to, you have the common perineum going down. So that's how you cut it and remove it. And once you are in between IT band and biceps, then you just release all the posterolateral lesions, and then you keep it there. So pie crusting of MCL, again, this is an important thing. This is MCL which goes from the tubercle to the distal insertion over the tibia. So this is the point where we do the pie crusting, distal to the joint line. There are different aspects of it. Some people go proximal and some people go distal. But this is the point where we try to give pie crusting technique. So the pie crusting, see this medial meniscus, this is how it appears. Only a probe can go. The probe is 4 mm, so only that goes. Your instrument, it is quite difficult to pass your instrument into that. If you try to pass your instrument, see you can see the tear there, which is just visible. But when you try to pull your duckbill, it is quite difficult. And now we are trying to give the incision there. You see how it is opening. Yeah, that sudden pop comes, and that's the point where you should stop. You should be looking at the junction of the middle third and posterior third, and keep giving the pie crusting. And whenever you listen the pop and it releases, that's the point where you should stop. It's an inside out. We have seen the model. So this is how the inside out. You put a single lumen cannula. You give the needle out, and you give the second needle in. You can go through the meniscus. You can go through the capsule. You can try. This is vertical matters that we are doing. We can even try horizontal mattress. The first suture usually goes in the center, in the bucket handle tear, so that it holds the meniscus like an anchor, and then you try to do it. Now when sir has shown the inferior stitch also, what happens is when you put 2-3 superior sutures, it averts the meniscus, and that's the point where you should go for so that's how we've taken a superior stitch. And then, so it is averted, and that's the point where we should go for an inferior stitch, as shown by sir in the morning. So we go inferiorly. That's a safety incision that you can see here. So whenever you take the needle comes out, that is how it is pulled out. The needle is pulled out, and then you take the second bite over the capsule, and even the second needle is pulled out. And when you take both the threads, it falls down. Yeah. So all inside, again, as I told you, that is in the posterior horn. These are different devices that you can use. This is an animation, you can get it online. And you have to, the only thing is, you have to know the measurement where you have to go. Like here, it should go behind the capsule, and the anchor should be there. So that's a video again. So the other For the radial tears and circumferential tears, you can use the scorpion-like devices and close it. So there are complications with the neurovascular injury, cartilage scuffing that needs to be taken care. Post-op protocol, in the first 3 weeks, it is partial weight bearing and movements. So finally, meniscus should be preserved as much as possible. And simple red zone, horizontal tears or vertical tears heal better. The solid fixation and augmentation of healing gives good results. Zone-specific fixation with adequate exposure needs to be done to avoid injuries. So inside out is the most commonly used, but posterior third needs all inside repairs. So adherence to post-op protocol will help in better healing. Thank you.
Thank you, Rajshekhar. Complex meniscal root tear. It was a very, very bad test, but very well performed. Thank you, sir. Thank you.
Thank you, and good morning, everyone. It's wonderful to be here in the beautiful city of Visakhapatnam. And on Sunday, this jam-packed hall. Usually, we from Gujarat, we see that Sunday people become very lazy and they're resting at home. And it's nice to see that all of are constantly sitting and with full concentration and interest. So there have been many talks on meniscus tear and repair since morning. So many things can be overlapping. So as you see the meniscus here, and now if we see the radial tear, it looks like a devil. And the radial tear can be a devil for a knee joint, because a radial tear acts as a, there are many studies that radial tear breaks the circumferential hoop stress of the meniscus and takes away its capability of shock absorption. And the effect of radial tear on the knee joints is equivalent to a total meniscectomy and increases the significant concentrated load on the tibia and the femoral cartilage. There have been many studies that it increases the load 3 times. So there are many types of radial tears. So type 1 is a partial tear which is extending onto the white zone. Type 2 extending into the red-white zone. Type 3 extending right up to the capsule, that is red zone without gap. Type 4 full thickness up to red zone but with gap of around less than 3 millimeter, and type 5 is more than 3 millimeter tear. So there are different ways of repairing radial tear, different mechanism. If it is like parrot beak tear, you can do a side-to-side stitch which using all inside or inside out. If meniscal tissue quality is not good, then you can use hashtag stitch. As Dr. Prathamesh Jain sir showed us, we can use this type of suture anchor with side-to-side repair and with meniscus to bone repair. Many times you will find that tissue quality is not good, then you can have hashtag type of stitches like side-to-side and inside-out combination stitches. You can use suture anchor, or you can use a suture pull-out also. So now we have different types of implants available. Various combination you can use. You can use a scorpion device and do side-to-side stitch and a pull-out mechanism. So there are different mechanism, whatever suits best in your hand, depending on the tear pattern, you can use that. So let's see one by one. This is a type 1 radial tear, just in the white zone. So what you require is just a meniscus balancing carefully and make sure that there is no loose ends so that it doesn't extend beyond. If it is a type 2 tear, you can do outside in or inside out repair. In this, it is a lateral meniscus, so we did outside in repair. You can use a Prolene or a fiber wire. You can use a number 20 or number 0 fiber wire also. And use your standard shoulder arthroscopy instruments for knot tying and the cannula. This is a type 3 tear, and you can see because of the neglected, there is a cartilage erosions also on the femur and the tibia. And here you can do a simple inside out stitches, vertical mattress and side to side mattress to avoid the cut through of the stitches. So this vertical mattress will avoid the cut through of this horizontal mattress. It will act as a rip stop stitches. So some people call it a hashtag stitches also. So combination of stitches on the superior surface and the under surface will provide compressive forces and avoid unnecessary eversion of the meniscus. This is a typical this type of tear we usually see on the posterior part of the lateral meniscus in young patient along with the ACL tear. and sometimes we treat as a root tear, just a suture pull out, or if the remnant of the root is good quality, then you can do side to side stitches using a small meniscus passer device like knee scorpion. So here there is a number 0 fiber wire. So first stitch is passed through the remnant of the posterior root. This tear was associated with the ACL avulsion in around 14 years old male. So first we pass the stitches of the ACL avulsion, then we are doing this root fixation. As you can see, there are some blood clots also visible on the posterior part. So vascularity is good, patient is young. So we decided unnecessarily we didn't want to do the transtibial repair. So just a side to side repair. When the knee becomes stable, the healing potential of the lateral meniscus becomes very good. And if you just take a stay stitches and knee becomes stable, usually the healing becomes very fast in such cases. So you, in your armamentarium, you should have such device always ready: knee scorpion, a small fiber wire, passport or normal cannulas, knot pushers, suture retrievers, because in normal ACLs, usually we don't require such instruments. But whenever you are anticipating such type of tear, these devices should be there in armamentarium. And sometimes radial tear can be such dangerous. There is a transactions with gap of more than 5 millimeters. It's a type 5 radial tear, lateral meniscus transaction, and it becomes quite challenging to repair. So in such loss, first we need to make sure that if both of these are approximating or not. If not approximating, then there is no point of repair. So first you use all inside or a side to side stitch just to see if both the ends are coming against each other or not. So we took a chance and they are coming against each other. So then we decided to go ahead with the repair. Here also multiple combination of stitches are required, side to side, then meniscus to capsule for both the fragments. Now we have fiber tapes also available. So in one of the such cases, we passed fiber tape and fixed to the tibia also for more stability. So here criss-cross mechanism, hashtag, and all the types of combination used. And in this case also ACL tear was there. So after ACL reconstruction, if we immobilize for around 3 to 4 weeks and non-weight bearing, then usually the healing potential of lateral meniscus is good compared to the medial meniscus in such cases. And in our center, we often do repeat MRI at around 4 to 6 months just to see the healing of such cases. So in summary, radial tear if missed can lead to rapid worsening of the knee cartilage. Using combination of various techniques required, on-table decision is required which type of configuration you want. Sometimes biological augmentation in fibrin clots required if it is an isolated tear. Along with ACL, there are usually oozing from the tibial or femoral tunnels, so it helps in the healing. Compared to normal meniscus, post-operative protection is slightly longer, like 4 to 6 weeks. It's up to you whether you want to do repeat MRI or not, but in sports player, I usually prefer repeat MRI at 6 months to confirm the healing of the meniscus. And many cases, as we saw in the live surgery, alignment should be checked prior to the surgery, and if it's required, then high tibial osteotomy should be added. Thank you.
Thank you, sir. Thank you so much. So we'll go ahead with the next talk by Dr. Ravi Sharma, Zip lesion and its importance.
Good morning, everybody. So my talk is on lateral meniscus zip lesions. So we'll start with this. He's a 16-year-old boy with a history of soccer injury. So as we can see in the MRI, there will be a this thing. You can see a ACL tear is there already. So whether there is any other lesion associated with it, as you can have a closer look at it, you can just see it may be just a normal variant, or is there a meniscal tear? So that is the big question. So there is a meniscal tear, but even if you say there is no meniscal tear, there is it may be normal because it may be a normal Risberg ligament itself. So coming to this, the relevant anatomy. So the zip lesion is a tear in the ramp corresponds to the ramp region of the medial meniscus. Similar lesion in the lateral meniscus is called as a zip lesion. So posteriorly, there will be the ligament of Risberg, to which the posterior horn of the lateral meniscus attaches. So what happens is, so it attaches to the femur on one side and to the posterior horn of the lateral meniscus in the tibial side. And when there is an anterior translation of the tibia during an ACL tear, the posterior horn of the lateral meniscus being attached to the more to the tibia, it will be dragged by the anteriorly, and posteriorly the translation will be restricted by the ligament of Risberg. So definition is, there should be a longitudinal vertical oblique meniscal tear at the junction of the ligament of Risberg and the lateral meniscus posterior horn, and it should extend 1.4 centimeters minimum in the mediolateral direction. So it is usually seen in the ACL injuries. So since the lateral meniscus is the major restraint for the pivot shift maneuver, once it will be torn like a zip. So that is the also called as the Risberg rip. So there you can see that it is ripping apart because of the restraint of the meniscofemoral ligament on one aspect and the attachment to the ACL on the other. So why is this important? Because any such tears, you need to repair it, and preservation is always important to prevent any future osteoarthritis. And these lesions are mostly missed. Even on an MRI, we cannot see. So for any case of ACL disruption, it is very pertinent that we do a scope and go to the posterolateral compartment and look for these lesions by probing these lesions. So this is the mechanism. So ACL disruption, so the tibia moves anteriorly. So anterior part of the posterior of the lateral meniscus moves anteriorly, and the ligament Risberg causes traction on the peripheral rim, and the posterior part of the posterior of the lateral meniscus remains in its place, and it creates a tear in the longitudinal fragment of the lateral meniscus. So it opens like a zip, and it's called as a zip sign or the zip lesion. So it corresponds to the medial ramp lesion. So already it has been explained why the lateral meniscus is more involved, because it is smaller, circular, more mobile, and there are weak or no connections with the LCL, and very loose connections with the capsule as well. So as I said, what do you term as a zip lesion, which is a longitudinal, vertical or an oblique meniscal tear at the junction of the ligament of Risberg and the lateral meniscus posterior horn, and the tear must extend more than 1.4 centimeters in the mediolateral direction from the lateral edge of the posterior cruciate ligament. So we need to be aware of the pseudo tear, which is not present on more than three slices on an MRI. It is a normal variant, and it is not present on successive slices. So a true tear, it should be present on 3 successive slices. So once again, it is very easy to miss on an MRI because the tears are very small and it's posteriorly located, and because of the complex anatomy, and the normal anatomy also may mimic as a tear. So it is very pertinent that we do a probing on arthroscopy. So it has been classified into 5 types. So type 1 is basically it is a superior meniscocapsular tear. It's partial. If it is in the capsule, you call it as 1A. If it is occurring in the posterior horn, we call it as the 1B. So if it is the same tear is in the inferior part, you call it as type 2. If it is in the capsule, it called as a type 2A, and if it is in the posterior horn, we call it as a type 2B. And type 3 is a complete meniscocapsular tear, and if it is associated with the posterior horn tear, we call it as a type 3B. And type 4 is a double tear where there is a capsular tear as well as a posterior horn tear. And type 5 is a radial tear, which actually we have seen with respect to the medial meniscus. Similar thing occurring in the meniscocapsular separation with a radial tear. So for examination of the lateral meniscus, we usually put the figure of 4 position, and both the AL and AM portal, but this is the arthroscopic image showing the zip lesion, lateral ramp. And you can better appreciate it on probing, and otherwise we may miss these lesions, especially in the lateral compartment. So this is we can see that there is a straight line of increased signal intensity in the outer 5 mm behind the distal insertion of the meniscofemoral ligament, which is indicative of these zip lesions. As you can see, there is as the arrow points out, the lesion in the sometimes in the femoral attachment and sometimes in the tibial attachment as well. So whenever there is a proven ACL tear, look for the PL compartment, not to miss the zip lesions. And figure of 4 position you should put when using a AL portal to identify these. And always use a probe from the AM portal to both probe for these lesions. And under surface tears, you can lift the meniscus with the probe and find it out. So when you have difficulty, sometimes if there is any doubt, always it is useful to put a posterior lateral portal, and this you can do either by using a PM portal and clearing the septum and passing the rod and putting an incision on the posterior lateral side, or you can put a spinal gauze needle just anterior to the biceps and put a posterior lateral portal. And posterior lateral portal may be useful for the type 3 and type 4 lesions repair as well. So coming to the treatment guidelines, so type 1A and type 1B, which is the superior lesions, sometimes may be left alone if they are stable, but from type 2 onwards, most of them will require repair. So what are the treatment options? We can do an all-inside meniscal repair, or you can use a posterior suture lasso techniques, or anterior you can use a knee scorpion and pass the sutures. So all-inside repair, as you have seen, you can use the all-inside either a sure stitch or whatever eco stitch. You have to use most of the instruments we put in the AM portal, and usually the limit is 16 to 18 millimeters, not more than that. That is the main disadvantage, because the main entry hole that we make is larger than the whatever anchor you are putting. There is a chance that it may come out. So that inherently it is little bit weaker in repair. So the device needle will be put through the anterior part of the meniscus to create a vertical mattress configuration. Then this is all inside. Then next one is the posterior suture lasso through the posterior lateral portal. Either you can put via the posterior medial portal or directly put a posterior lateral portal, and then you put a suture lasso, take a bite from the meniscocapsular junction as well as the one bite and pass the fiber wire, and take a second bite from the meniscus and tie it posterolaterally only. Or if you have to take more than 2, you can park it in the posterolateral portal and tie it anteriorly from the anteromedial portal. The main problem with the posterolateral portal is establishing a posterolateral portal, but it is required if they are type 3 and type 4 tears, which cannot be very correctly repaired by using just an anterior portals. So with the use of a knee scorpion, we can get a much more deeper bite. So for this also, we put the knee scorpion through the AM portal and pass it below the meniscus and grasp the full thickness of the meniscus posterior to the tear. Then you can get the fiber wire through the meniscus full thickness, and it is better to create a central transpatellar portal and take it out, and once again take another bite, and so that you can put a vertical mattress configuration. So this is the knee scorpion. So what is the rehabilitation? Day 1 we do a quadriceps tightening, ankle pumps and SLRT up to 2 weeks, total weight bearing. From 2 to 4 weeks, 0 to 90 degrees motion with partial weight bearing, and after 4 weeks, full weight bearing. At 6 to 8 weeks, we can allow for a full range of motion. Squatting will be allowed only after 6 months. Return now to sports activities is also permitted after 9 months. So what is the take-home message? It is very important that we suspect and look for a zip lesion in the posterolateral compartment when there is a proven ACL tear. Use a probe to check for tears and their stability. Use a needle to identify the tears. And scope in the AM portal will be better to visualize these tears. Always you try to preserve the meniscus so that we can preserve the joint. Thank you.
Thank you, Dr. Ravi. So I would like to invite Dr. Santosh Savanan for his talk on discoid meniscus, things to know. So for all the delegates, sir is the one who performed ACL and all inside meniscal repair, our first live surgery. So sir is a knee surgeon from prestigious Ortho One Institute in Coimbatore. So he has numerous publications and his own techniques. So apart from that, he is a very good surgeon and a good human being. Welcome, sir. Welcome to Vizag.
Thank you for the generous introduction. Good afternoon, all. It's a pleasure being here. Thanks to the hospitality and thanks to the SRS team for inviting me here. And thanks for the old friends who are the chairperson here, especially Ramaraju, who is my PG batchmate. Nice to see him after so many years. Okay. So my talk here is on discoid lateral meniscus. So what all are the things which you need to know when you are dealing with discoid lateral meniscus? Okay, so basic classification of a discoid lateral meniscus. You must be aware of this classification, Watanabe. As we've seen in the previous talks, the Risberg ligament, whether the lateral meniscus is anchored to the tibial plateau or not. Based on that is this classification. As you can see here, the type C, there is attachment of the Risberg ligament, but there is no attachment onto the tibial plateau. Other thing is the complete, incomplete discoid. So you must be aware of these variations in the lateral discoid meniscus. Usually you come across this lateral discoid in the adolescent age group. They would present with the locking symptoms. So based on that, whether they are adult or not, whether they present with locking or clicking, and whether there is pain or not. All this decides when you need to address them. Sometimes you might incidentally find a lateral discoid meniscus in an MRI. That doesn't mean you have to go in and address it. Unless it is giving you clinical symptoms, it's not really necessary. But debate comes if you are doing some other procedure like an ACL and you see a lateral discoid, what to do. Some advocate trimming it, some say it is normal, leave it. MRI might show intra-substance changes, which again makes things confusing whether to deal with it or not. So those are the factors which you need to know, and these are the warning signs which are available with the X-ray itself. You can suspect an lateral discoid, but with the advent of MRIs, it's hardly become relevant nowadays. So there are points which during our PG days we used to have the 6 points as an exam question, but in clinical practice it is mostly relevant because of the use of MRI nowadays. MRI wise, you must be aware of this classification. When there is a tear, you must be aware of this ARN classification, where it's a discoid meniscus with which is no tear is seen. There might be a tear in one part and it will be subluxed towards one part. So there might be a posterior tear and the entire meniscus will move forward. This is actually a radiological classification which is very useful for an arthroscopy surgeon. Type C is a tear in the anterior part and the entire meniscus subluxes posteriorly. And this is a central type, central subluxation, which comes forward. The challenge for an arthroscopy surgeon is the type B. Because of the meniscus is subluxing forward, you can hardly see the meniscus arthroscopically. The notch will be filled. It is very challenging to go inside. So you might need to trim down majority of it then to decide whether you will be able to salvage any meniscus. The entire talk is on whether we can excise the lateral discoid and remove it and throw it away. It's going to be a subtotal meniscectomy. So how much can we salvage is the problem here. So slowly trimming it and then slowly visualizing it and then tracking it, deciding on what to do. This is an arthroscopic video where you are seeing the complete lateral discoid meniscus. Running through the videos quite fast so that you can see more of it. First you need to probe and see is there any tear which is there. It might just be an intra-substance tear. That's a free edge. This is a complete discoid meniscus. So for us it's a clicking type of a meniscus, so we have to trim it down. So the instruments which you use, again you have to be very careful in choosing them. I use the right curved oval punch. So advantage of using an oval punch is that it balances, your edges are shaped as you keep cutting and going rather than using those square punches. So you don't need to balance it after you trim it down. So you balance step by step and shave, remove it, keep balancing, see how much of stability is there any intra-substance tear, horizontal cleavage in between. And here the judgment is how much to leave behind. That is again debatable. So you leave behind at least 1/3 so that you don't leave behind anything unstable. At the same time, you must leave behind some meniscus because this knee had developed and grown with that meniscus in place. So just taking everything off, this knee is not used to that, so there is a chance of wear and tear. So a discoid meniscus for that individual is a normal meniscus. So unnecessary removal should be avoided. So how much to leave behind? Again, there are a lot of literature. 6 mm is one landmark where minimum 6 mm must be left behind. 10 mm is another one. So that's again debatable. 1/3 is an approximate value you can leave behind. So after trimming, if the remaining edge, this is another discoid, this is another case example. This is a central type. As you can see, the discoid is come forward and you can see a gap over there which was rasped now. So you trim it down and as you trim it down, you trim it down just enough so that when you reduce it, the meniscus would go back. So don't take a judgment straight away, do it step by step. You trim it down, shape it, keep it to a shape, and then push the meniscus back and check whether it is a reducible meniscus. You trim it down just for increasing your visibility, then repair it, and you can trim again as a second stage after you finish the repair, after pushing the meniscus back. This is the central type, slightly easier to do. You freshen the periphery, then you can use inside out or all inside sutures. For dealing with the anterior horn, you can see these are right angle punches, not the regular punches. You cannot reach the anterior horn easily. So you need to have accessory medial portals in case you are not able to reach these areas. These are challenging cases, especially pediatric cases where knee is very small, instruments might be big, you should not scuff the cartilage. So here you try to reduce it, and you, as this is posterior part of lateral meniscus, you need to do all inside devices over there. The number of all inside devices, again, as I showed in the morning, you can use it from the medial portal, or you can switch and use from the lateral portal. Other alternative is used to have multiple firing all inside devices, which might give you vertical continuous sutures, as already shown in one of the talks over here. So to run through a little bit more, I'm not able to forward. So there will be an all inside sutures coming there and placing, as we've seen earlier in the day. So I'll skip through this. Let's go for the next type of tear. This is another tear. As you can see, this is almost, sometimes we mistakenly call this a ring type meniscus. So part of the meniscus is the notch, and that's the remaining. So the entire meniscus has to be pushed back, and that's the popliteus hiatus. So getting this back is a big challenge. But in a young individual, if you're not pushing it back, it's going to be a subtotal meniscectomy. So here, part of it was trimmed down initially as a first phase. Then using these punches, keep changing the punches so that you can visualize better. Then, because reduction, it's a chronic subluxed tear, reduction will be challenging. So you need to place reduction sutures. Inside out will be challenging. Here, such kind of suture passing devices can be passed, and these are used as reduction sutures. Those sutures are taken out through a separate portal laterally through another portal, and these sutures are pulled to reduce the meniscus back in place. Then you keep passing additional inside out sutures and all inside sutures alternatively to reduce the meniscus back in place. So in short, DM is very common in children. Only symptomatic cases, which is either locking or pain, needs to be addressed. Clicks sometimes might be asymptomatic, you might not need to address them. Partial meniscectomy combined with repair is the treatment of choice. For anterior horn mobility, meniscopexy can be done, and the thickened meniscus, saucerization or meniscoplasty can be done to shape the meniscus back in place. These are the recent advances, and this is how we should deal with the lateral discoid meniscus. Thank you very much.
Thank you, sir. Thank you so much. So we'll go ahead with the next talk because we are awaiting the inauguration session now shortly. So we'll go ahead with the talk by Dr. Santosh. How do I approach degenerative horizontal tears of the meniscus?
Yeah, good afternoon all. I'm here to discuss about the degenerative horizontal tears of meniscus. I am working as an associate professor in GEMS Hospital. And here the introduction, the meniscus degenerative microscopically and macroscopically within aging process, and the resulting in pain in the knee dysfunction. And here the anatomy, these all things are discussed previous slides, and this is meniscus are C-shaped, which one is more semicircular shaped, which says lateral one, and C-shaped one is medial one. And this is medial meniscus, this is C-shaped one, and here we have to, it's not working. And here the posterior horn is larger than the anterior horn, and the anterior horn of the medial meniscus Okay, anterior horn of this medial meniscus is the film and bony attachment is there. And here we have to know that these capsular attachments of medial meniscus onto the tibia and known as the coronary ligaments. And these are the thickened along the mid portion of the and deep medial collateral ligaments. And this is the lateral meniscus, which is semicircular shape, and it is more mobile compared to the medial. So the medial injuries are more. And here the ligament of Humphrey and ligament of Wiesberg, these two are important to attach the connections to the posterior horn and lateral aspect of the medial femoral condyle. These are all the anatomy, and these are all the various footprints on the tibial side. This is lateral meniscus, which is seen in the lateral meniscus is semicircular, and the medial meniscus is C-shaped. And microstructural composition, approximately 70 to 75% of the meniscus is water makes up. So the degeneration process is more with aging process. And these are the things which anatomically, this is red zone and red white zone and white zone. And with the tear of white zone, it is more complex one. It is less chances to heal. So the chances of healing is more in red zone and red white zone. These degenerative tears are more seen in the white zone, which is horizontal tears. So the treatment of choice is vary with that horizontal tears, these degenerative tears. And these are all the meniscus functions. These are all the already discussed with previous talkers. This is load transfer and shock absorption and stabilization, and it contact stress reduction and lubrication and proprioception. If the meniscus is not there, in the meniscectomy patients, the contact will be limited and high contact stress will be there. If the meniscus is intact, the contact stress is less. So osteoarthritis chances are less. And meniscus tear types, these are the acute one and degenerative one. We are now discussing about the degenerative tears. These are the types of meniscal tears. And longitudinal tear, this longitudinal tear displaced into the intra-articular and intracondylar area, and it is called it as a bucket handle tear. And these are the horizontal tears and radial tears and flap tears. These horizontal tears are more commonly seen in degenerative tears. And degenerative tears generally have complex tear pattern and are predominantly found in posterior horn and mid-body. The posterior horn of medial meniscus is most commonly involved, and mid-body of lateral meniscus is most commonly involved in these degenerative tears. And there is one study showed that degenerative meniscal tears were associated with outer beast 2 chondral degeneration are more than 85% of time, and compared to 12% flap tears and 0% longitudinal tears. One more study, the knee arthroscopically seen that the meniscal tears found that patients with complex and horizontal tears are significantly more likely to seen in outer breast type 3 and type 4 chondral lesions, which is seen in osteoarthritis. This is one more study showed that rate of medial meniscal degenerative tears are higher in, not higher in those who develop the osteoarthritis. So the degenerative tears and osteoarthritis tears both are mimic same, and the tears are more commonly seen in the horizontal tears. These are the tears, horizontal tears, where the common in older patients, seen in posterior horn of medial meniscus, in the mid portion of lateral meniscus is most commonly seen. And these horizontal tears have a superior flap and inferior flap, which is showing like a fish mouth. Okay, so this is which is seen in the white zone. So the minimal healing capacity. So here comes the whether we are going for the arthroscopic meniscectomy or meniscal repair, or we have to do it as a conservative treatment. But while going for the repair, the healing capacity here is very less. So we have to go for first the rehabilitation protocol, and you have to give some conservative management. If it is not works, then we will go for the arthroscopic debridement. And if the part is more to the white red zone, then we will go for arthroscopic repair of the remnant part. And this is the sagittal section and coronal section. The body and the horns will be seen like this in the horizontal tears. In sagittal section, it is like 1 and 2, and this coronal section it is like 3 and 4. You have to identify it in the MRI, which is explained by Dr. Manoj. And the risk factor, it is more older age, and BMI if it is more than 25, then work-related repeated squatting and kneeling and ascending stairs, which causes those horizontal tears or degenerative tears. And the presentation, patient presents with typically knee pain and locking and clicking, popping, and these things of clinical presentation. And you have to examine these patients with joint line tenderness, and symptoms may include locking and palpable audible clicking during the knee movement. And initial examination, you have to visually inspect, should check the signs of erythema, wounds, and ecchymosis and deformity, which is seen in acute injuries, and compare with the contralateral knee. You have to compare with contralateral knee. And here the joint effusion and range of motion also you have to see. And these are the diagnostic accuracy, the joint line tenderness and McMurray's test. And these are all the imaging MRI techniques. These things already, this one. And here come to this one, we have to go for non-operative or operative thing. Here the non-operative thing, first patient complaining with pain and some difficulty, you have to give some painkillers and give some rehabilitation, and patient should limit the activities, then we should go with that one. If it is patient not pain-free and the symptoms are not reduced within the 4 to 5 weeks, then we will thought for arthroscopic debridement for the patient. And these are all the physiotherapy exercises we have to do. And here the arthroscopic partial meniscectomy, that through the arthroscopic examination, if the chondral surface and joint space and meniscal things are there, is there any loose bodies, you have to remove that one. If the pain is persists, then we will go for the arthroscopic meniscectomy. This maybe you can go for partial meniscectomy, subtotal meniscectomy, and total meniscectomy. These days, these two are eliminated, subtotal meniscectomy and total meniscectomy. You have to preserve as much as your meniscus. Then you should remove the partial meniscectomy, meniscal debridement. If the thing is more in white to red zone, then we will go for the repair of remnant part. And these are all the things. And these are the technical meniscal repair. They are also explained. And these are all meniscal replacement things also there. And here there is a lot of generals. This is American Journal of Sports. There is no difference found in rehab compared to conservative management and arthroscopic meniscectomy. And this is also degenerative meniscal lesions, conservative versus surgical management. Here they reviewed articles, various articles from 2000 to 2020, total 12 papers, which are 3 papers treated conservatively and 9 papers treated arthroscopic meniscectomy, where they concluded that the arthroscopic meniscectomy should be proposed for the patients who is suffering from the pain and this discomfort after treating them with conservative. The conservative management is first in the first, and this thing is not workful, then only we will go for the arthroscopic meniscectomy. And this is also one literature which is shown that the systemic review agreed that middle-aged patients with degenerative meniscal tears, arthroscopic surgery has no long-term improvement in the pain and function over the exercise therapy and conservative therapy. And that conclusion here, there is a patient fall in improve after the conservative treatment and find relief undergoing the surgery. If the patient is failed, then only we will go for the surgical management. And these all generals are concluding only one thing. The thing is, the conservative management is more than surgical management in this degenerative tears. Where the surgical management comes place, the rehabilitation and conservative management will not work. Then we have to do the patient for arthroscopic partial meniscectomy, and remaining thing will be treated as arthroscopic repair. And this is the conclusion. And non-operative therapy focused only NSAIDs, anti-inflammatory and physical therapy may be able to provide pain relief and as well as improve the mechanical function of the knee joint in these degenerative tears. These are most commonly horizontal tears. Okay. And this is our department. Thank you.
Thank you, Dr. Santosh. I think we'll go ahead with the inauguration now. Thank you. Thank you so much.
A short inauguration ceremony. So before inviting our distinguished guests onto the stage, I would like to introduce our chief guest for today. So the City Commissioner, Dr. Bagchi sir. Sir, we are very happy to have you here, sir. So a big round of applause for. So despite his busy schedule, sir has accepted our invitation and come to grace our occasion. And if I'm not wrong, I think sir has taken charge on Doctor's Day 2024. So that is indeed a very warm and welcome coincidence for us. So since then, I think our city has been in very safe hands. So first, I would like to invite our beloved professor to many of the students here and a very respected figure, Dr. B. Uday Kumar sir, onto the stage. Rajesh, kindly present. So it is indeed a great honor to invite our chief guest for today, Dr. Bagchi sir, onto the stage. Rajesh, you can accompany. And Professor Uday Kumar sir, I would request sir to present a bouquet to Bagchi sir. So now I would like to invite our prestigious and very respected guest, invited faculty for today's conference, Dr. Prathamesh Jain sir from Ahmedabad. Dr. Rohan Vakta sir from Ahmedabad. Dr. Santosh Sahanand sir from Coimbatore. So from the Department of Orthopedics, KGH, so Dr. Chandrasekhar Naidu sir. So executive member IAS1 and our very arthroscopy in charge, Dr. Sridhar sir from Medicover Hospitals. So Sridhar sir has recently been elected as the executive member IAS1. Sir has been continuously putting Vizag on the arthroscopy map since many years. So now we'll proceed with the lamp lighting ceremony. 1 minute, we'll have a group photo and then proceed. So at this point, we would also like to announce again, we might forget later. So both the live surgeries have been streamed from KIMS Hospital, Seethamdara. So unfortunately, we are not having any representation right now, but sir will be joining us shortly. So we thank KIMS Hospital as well. Sir, I would like to invite Dr. Vasant Babu sir. Sorry sir. Sir, please come on to say. So sir is the, sir please, medical superintendent of KIMS Hospitals. So they have arranged all the logistics for the live surgery. So thank you so much, sir. So the APMC observer, Dr. M.V.S. Baparao sir. So kindly come on to the stage, sir. we would now proceed with the lamp lighting ceremony. So I request Dr. Babji sir to do the first. So now I request our honored chief guest and respected Dr. Bakshi sir to kindly give his message on this.
Respected senior orthopedicians participating in this conference on Advanced Knee Arthroscopy Course is also being hosted by KIMS Hospital, Icon Hospital, and all other distinguished orthopedicians from different districts of North Andhra, Coastal Andhra and Godavari districts. At the very outset, I must acknowledge that I feel proud and privileged to be invited as the chief guest for inaugurating this course. We all know that meniscal injuries are quite common. Athletes getting these injuries when there is sudden twisting of the knee. But meniscal injuries are also common in case of degeneration. Around 200 years ago, when this meniscus was first recognized, it was felt that meniscus is an unnecessary appendage. But after Fairbank told us about the importance of the integrity of meniscus, how the loss of meniscus causes osteoarthrosis of knee, the importance of saving the meniscus, preserving the meniscus has also dawned upon the orthopedicians for so many decades now. So whenever someone with meniscal injury or tear comes to an orthopedician, every orthopedician first tries if it can be preserved. I was also going through the presentation that was being the orthopedician who was presenting one PPT on just when after I came, he was also focusing on the same factor, important that if we can preserve the meniscus, if conservative therapy with physiotherapy succeeds, nothing like it. Now, it has also been seen, the orthopedicians, you all know that an isolated meniscal tear, especially related to degenerative meniscal injury, the prognosis is worse compared to meniscal tear along with ACL injury that is commoner in younger patients, because the meniscus is not degenerated in such patients. We all know that a meniscus has two parts, the central avascular zone and the peripheral vascular zone. And when there is tear in the peripheral vascular zone, the repair is easier, the healing is faster. But the problem arises when the central avascular zone gets torn. Now the dilemma comes whether to go for surgery and remove the meniscus partially or completely. We all know that total removal of meniscus, total meniscectomy may make the patient prone to osteoarthrosis knee. So I think more and more techniques are coming. Research is being done as to how to ensure better healing of the torn avascular portion. We have heard of transplantation of allografts, better suturing techniques in case the better suturing techniques can help in healing of the central avascular zone. And if the meniscus has to be totally removed, then there is a lot of studies, a lot of research as to whether transplants can be done so that the degeneration, the future osteoarthrosis of knee can be avoided. So a lot of research is going on, a lot of study is going on, a lot of advances are happening in this frontier. And I appeal to all the orthopedicians that we should focus on healing of the torn meniscus or preserving the torn meniscus to the maximum extent possible so that the patient can get a normal knee joint back. I'm sure you must already been doing it. And also the patients will come to us after meniscal tears in the hospitals. If we can have some posters outside the orthopedics department about what are the factors causing meniscal tears, how to avoid meniscal tears, what sort of unaccustomed exercises to avoid. So people will be more aware. I think more awareness needs to be created to prevent such tears so that the need of surgery itself doesn't arise. I had gone to US in 2005. That time only my friends there in US, they told me, many of my doctor friends are settled in US, that how much specialization has been done in US in different fields of medicine and surgery. If for every finger, they told me, people are specializing there. Surgery on the index finger of the right hand, surgery of the middle finger of the left hand. It seems there are specialists there. So when I find that a workshop is being held only on arthroscopic, advanced knee arthroscopy course focusing on the meniscus, I felt very happy. This is what we should aim at. More specialization and more specialization. So that the best techniques of arthroscopy and meniscal preservation techniques can come out of North Coastal Andhra and Godavari districts from the orthopedicians here, and the knowledge and the expertise can be disseminated to other orthopedicians across the state. Perhaps the more we do surgeries, the more we do research, we will have better expertise, and I am sure such workshops go a long way in honing our skills, improving our knowledge, and especially for the PGT students of orthopedics. It is like a blessing. Such workshops will help them a lot in their future career. I have come across so many senior orthopedicians coming from all over the country who have come here to participate and share their expertise and knowledge, as well as I think because of live surgeries, we'll also see their skills from KIMS Hospital, the renowned orthopedicians doing live surgeries. So it's a great opportunity, a golden opportunity, and Vizag, the city of destiny, is proud to host this workshop, and I only hope that more and more such courses will happen in Vizag in the days to come. The orthopedicians from across the country and the world will flock to Vizag, and there will be more knowledge sharing, more experience sharing, and the patients of Vizag city, the patients of North Coastal Andhra, the patient of Godavari districts, and the patient from Odisha and Chhattisgarh, they all flock to Vizag. All of them will benefit from such workshops and from this sharing of experience, knowledge. So this is a win-win situation for patients, for doctors, and for all of us. So we are very proud that this workshop has been organized in Vizag by KIMS Hospital. I wish more such workshops in the days to come, and I extend my heartfelt greetings and congratulations to the host of this conference workshop. I am waiting for more such courses to happen in Vizag in the days to come, and from police department, all help will be extended to everyone. Just one more thing before I end my lecture. For people, for the doctors, orthopedicians who are in Vizag, I just wanted to share my number, 7995095799. In case in your domestic life or in your neighborhood or in your hospital, you come across any problem where police can be of some help, please don't hesitate to give me a call or send me a message to WhatsApp. I will personally ensure that your problem is solved to the extent possible, whatever is in my hands. And this number is my personal contact number. I pick up the number 24/7. Even if I am in some meeting, I will call back. So you can share it with your friends, family members, and colleagues. I hope that all together, all of us will make Vizag the best city to live in the entire country. Thank you. All the best.
Sir, we are really overwhelmed by your affection and the depth of knowledge you have in the orthopedics, sir. Sir, really, can you tell us? So, more than we know some of the subjects, sir has told me, the middle and avascular part and my horns of the avascular parts. Thank you so much, sir. And Vizag has been peaceful, sir, as of today. Half you have taken over. But our small, because orthopedicians and police have a very close relation, sir, because we are attending court and so many things, accident cases. My only dream, sir, I want to see the lane discipline in our Vizag, sir, because
that will also come. We are going to start an AI-driven traffic management system.
Yes, sir.
Where everyone will be monitored by CCTV cameras.
Yes, sir.
So no one will be able to escape if anyone commits a mistake on the road. So very soon going to be implemented.
Sir, it is our dream, sir, because orthopedicians, sir, it is a mostly preventive aspect, sir. Once accident happens, very difficult to bring him to normal status. So prevention is always better than cure in orthopedics, sir.
Very soon your dream will come true.
Thank you so much, sir. Now it's my pleasure to present a small token of gratitude. our appreciation to...
So I request Vasan Babu sir also from KIMS Hospital to come. Sir, thank you, sir. Thank you so much from one and all the delegates and the organizing committee as well. Thank you so much. So we'll continue with our scientific sessions. Now there will be a panel discussion. It will be headed by none other than our Sridhar sir. Yeah. Sir, Sridhar sir. So, yeah, we'll be inviting the panelists. We have a great panel lined up. So we will be having Pratmesh Jain sir, Rohan Vakta sir, Santosh sir, K.S. Praveen sir, and B. Gangaraju sir. So they will be heading the panel discussion. And also I would request K. Ramaraju sir and V.V. Rajshekhar also to join the panel.
Very good afternoon, everyone. First of all, I would like to thank the team SRS for their wonderful approach to the arthroscopic educational programs in Vizag. So last year we had IS1 knee done by us and IS1 shoulder done by them. So now we are coming up with an Advanced Arthroscopy Course today. So we had an excellent faculty all over India. So straightforward, we will go ahead with the panel discussion. I am keeping it much simple. Keeping in view of younger generation or the younger surgeons who are coming up in Vizag or northern part of Andhra NAOA members who are going more and more into the ACL and then slowly to the meniscal repair sessions. Santosh sir, please. So I'm just showing one case and we'll go more ahead with what are the things to taken care of or what are the things to be considered in a meniscal repair. So this one case by 18-year-old female with 3 months old injury, so complaining of the right knee, and I'm directly straightforward going to the arthroscopic view, sir. So it's a longitudinal tear of the meniscus. So what are our considerations seeing such tears in our regular practice? So what are our criteria, sir? So we'll discuss what are the different aspects in meniscal repair. So does age plays any role in meniscal repair? So Dr. Rohan sir, so starting, age is a criteria when you are seeing any meniscal tear in a patient?
Yes, so younger the patient, we should be more concentrated on meniscus repair. Even in chronic tear, but in younger patients, if you think on table that it is a repairable, then don't think about the vascularity, just give attempt of repair. So age, younger the patient, younger means less than 45 years. So between 15 to 45, whatever is can consider as a young for meniscus repair.
Yes, sir. So your cutoff is a 45. Pratmesh sir.
The chances of healing is definitely more if the patient is young. But I would emphasize meniscus repairs in all the cases as far as it is possible. So nowadays the criteria of meniscus repair is expanding, the indications are expanding. So what we should consider as an orthopedic surgeon, as an arthroscopist, is to try to conserve more and more meniscus and try to repair more and more meniscus. You might get a high rates of failure. So supposedly if you do a meniscus repair in an old patient, you might have a high rate of failure. So supposedly if I say I'll do a meniscus repair in a young patient, I may have a like 2%, 3% failure rate. If I do in little more age, it may be like 5%, 7%, 8%. But still that 90% of them would have a good healing. So I would appreciate, or I will motivate most of you to consider doing more and more meniscus repairs.
So that we can save the meniscus. So what about the chronicity, sir? Like how old tear you would like to repair that? So acute and chronic tears.
I would like to make the judgment more on the arthroscopic picture per se. And even
so you will decide intraoperatively.
Yeah, and even if it is chronic, and this the case we did, the
yeah,
was very
radial
bad,
one, yes.
But if you can combine it with alignment, then you can give a very good result. So even bad tears do heal, provided you give them vascularity, provided you give them alignment, and provided you give it approximation.
So is there any time limit, like beyond that we should not attempt any meniscal repair?
So sometimes it is very difficult to find out when the tear happens, because
Yeah.
the patient will come to you and will not give you a discrete history of the event or an injury. And then when you, the most common problem with which these patients will give you is pain.
Yes.
And sometimes it is very difficult for us also to know that how chronic the tear is. So I would not place much importance on the date of injury or time of injury. If I will ask the patient once, if he is fine and he remembers it is fine. If he does not remember, I take my clinical.
Now, usually most of these patients we get initially immediate post injury, they will have some pain, but maybe around 3 to 6 weeks down the line, they will have reduced pain and they do their activities. But after some time, they will come back again with the recurrence. Yes. So is there any zone specific on the location of the tear? So do we decide on location of the tear?
Sir, as I have shown in the presentation, sir, in the before slide, there is no impact of age or chronicity of tear. It mainly the impact is on the zone. If it is in the red zone, repairable tear, and we enhance the healing with the biologics and we give it a solid fixation, it usually heals. That is should be our prime target. And if it is a irreparable tear where there is a flap part, we remove the part which is not stable enough and repair as much meniscus tissue as possible. So that should be our aim.
So depending on locations or anything. So we'd like to repair more on the posterior horn or body or anterior horn, anything like that, or anything which is repairable is okay for us.
Yes. So definitely the chances of healing is more if there is a red zone, then red-white, then white-white. But still, most of these repairs, the only change I would do, if I would have a very white zone kind of a tear, maybe a vertical tear, I would not do a lamina specific repair. Means I would not repair it from the upper leaf. I would do one up and one down.
Okay.
So I would just do a more of a up and down repair. Rest of everything I would repair, regardless of the zone. Explaining to the patient, giving him or her the prognosis that I am doing this. You may
So always tell him there is a chances of failure.
Higher chance of failure, but still there is no harm attempting the repair.
Yes.
By the time we move on.
Yes, sir.
So we are talking about chronicity. 10 years back, we were talking about the things similar. 5 years back, few things changed. Now it is changing more. It's evolving. Chronicity. So we are talking about allografts for meniscus replacement. So when the meniscal allografts can heal to a native structure, whatever chronic native structure is going to heal. So with the experience of our radial tears, repairs have healed, we know white zone also heals. So we are being more and more aggressive. But the downside must be, as Sir had said, the patient point of view. Our patients must be an understanding patient. If we are too aggressive in a laborer, he might tell our surgery was a failure. So we must understand the patient, and the patient must understand that there is a return.
What is the prognosis?
If they are an understanding patient, in our clinical practice, repair as much as possible. Because sometimes they come asking for it. But if the patient doesn't understand, that might be a problem. So all these...
Yeah, always explain the patient. So there can be a chance of failure and you may need to redo the surgery again.
So elderly patients, degenerative tears, we add some biology to it to enhance the healing. Mostly like a microfracture, something like that can be added, where that the degenerative tears will heal when compared with, because young meniscus will definitely heal, but old degenerative will add some biology to it.
So by the time sir makes it, so when do you say that your meniscus has healed? Is it clinical? Is it radiological? Or you're saying that the chance of failure what is that failure mean to you?
So failure is when the patient comes with complaints. So if you do an MRI even after 2 years, there is no clear, there are noise signal ratios which are there, which is only an arbitrary thing which will give us an idea whether that's healed or not. Sometimes when you go in and see, it might be just the sutures which are holding on, and still you can see a gap. Probably the sutures are the ones which are holding, and meniscus is never healed, but the patient is asymptomatic. Still we cannot call that a failure. So when the patient becomes symptomatic, probably that's the failure. even if the patient goes on to develop arthritis, I might not call it a failure, but literature might call it a failure because you still go on to have arthritis, and it's multifactorial. Whether ligament instability was there, whether it was reconstructed, varus was there, cartilage defect was there. So it's multifactorial.
Yes, sir. So there are some studies which have showed that long-term results after the meniscal repair, like especially when they are done in a younger age group, there are high chances of re-rupture rates. So as high re-rupture rates in between 10 to 22 years, and also children and adolescents have a higher re-rupture risk than adults. So do you see that in our regular practice, sir? Is there any change, or we just attribute because of their higher daily activity level?
So they are more active. There are more chances that they will be going into the sports and competitive things. So that is probably the reason. But like any other orthopedic teaching, we all know that the fractures in the children heal very fast.
Yeah.
So it is similar for the meniscus as well. But definitely yes, if you are doing more high demand activities, more competitive sports, then definitely there is a
high chance of re-ruptures.
And the other thing is, occasionally this healing in the meniscus, occasionally it can be, it will not be like we call it, maybe a fibrous sort of a healing. So there may be a healing, but when there is a re-injury, the meniscus can
give way,
tear from the same spot.
Same spot. That may be a weakest point, our repair point. So this is another study which has showed that 33% retear rate in chronic repairs compares to only 14% in acute. So that's one thing to be noted. So what are the factors to be considered in a bucket handle tear or a meniscal tear, sir? Like reducibility plays an important role.
So for any bucket handle tear, so we do have come past some cases in which the patient is walking on the bucket handle tear for years.
Yeah, exactly.
And some patient may come to us like 2 years, 3 years with a FFD, with the patient walking in the same attitude.
Correct.
And those patients, you may have the bucket handle actually fibrous to the cartilage and the tissues.
And sometimes it gets healed up with the ACL.
Then it becomes very difficult for us to reduce. But most of the cases, if you are doing fine, you are doing the right releases, you do the pie casting, you will be able to reduce the bucket handle. Rarely, 1 or 2 times I have the issue that I was not able to reduce the bucket handle tear because of the chronicity. And usually the other technique is you can use a traction suture, like an inside-out, 2 inside-out needles, and you put a traction suture and try to reduce it. It was not coming with that also, and then I have to probably excise it. But then it is very, very rare to have that sort of irreducible.
But mostly it is of chronic bucket handle tears. They are all chronic bucket handle tears.
99% it will be reducible.
Right. So if you are, what are the things to be considered before attempting a repair? Like we shave the inner margins, rasp it, cure it, anything else?
So reducible and unstable things need to be anchored first. So that's the most important thing. So we might reduce it with valgus force and all, but when we flex it again, it comes back. So get the first suture right, pull it from outside, and that gives you a lot of freedom to use your other sutures. So that's the first thing. And regarding this pre-repair techniques, as I have shown in my presentation, the physical methods of abrasion, synovial abrasion, putting some vascular channels and all that, and biological methods are not really proven, but we can add fibrin clots into the horizontal tear, give a PRP after doing...
That is coming up, Rajshekhar. So don't take up a whole panel discussion now. So this thing you prefer rasp or shave or what else? Preparing the tear margins.
So rasp and shaver both, but while using shaver, you have to be little careful. You can close the suction of the shaver.
Okay.
And remove this frayed margin, make it little smoother. Sometimes this meniscus is very flimsy. If you keep the shaver on, it will eat out more tissue.
It may suck out.
Will end up in the meniscus loss. So be careful.
We may cut the meniscus.
Yes.
Yeah. So what about pike resting, sir?
So pike resting is definitely helpful to avoid the cartilage scuffing. And I don't see any contraindication of pike resting. But where, as you mentioned, there are different locations. On the femoral side, some prefer from inside the joint and release the capsule under vision. And on the tibial side also, my preference is posteromedial side or the distal MCL?
Pratmesh sir, on the femoral side or mid-joint level or on the tibial
you
side?
can do it at any place. I usually, what my criteria is, I would do it in the direction of the tear. So if there is an undersurface tear, I will do it towards the tibia, because then the tibial side will open.
Okay.
If the tear is more on the superior surface, I'll go little up. By and large, it is basically the posterior oblique ligament area. So it is posterior to the midline, but it depends on where you want to place your sutures and which is the main part of the tear. So the main part is, like when we are discussing the ramp, we are discussing about 2, 3 and 4. So 2 is upwards and 3 is downwards. So if the tear is more under surface, then I would do it on the on the tibial side. If it is on the upper surface, I'll do it on the femoral side.
Santosh sir, you've been quite.
When contraindication wise, in a valgus knee, I would be little cautious of doing it. Otherwise, it's the same as mostly I prefer the tibial side. And the other point, tip is while using the shaver for debriding, 3.5 mm shavers, non-serrated blades with the smaller oval opening is ideal, which will not bite away a lot of tissues, both cartilage as well as the meniscus.
So what about the suture?
There's one magic point which is described by Dr. Bancha recently, where there is one point of repair where they have taken a landmark as the adductor tubercle and the posterior tibial margin. On the femoral side, there's one point called magic point. If we just poke it once, it just opens up. That is one more thing, instead of repeated pokes.
Right, sir. So next will be what will be the suture pattern. So if you are repairing it, whether it's a vertical mattress, horizontal, crisscross, what would be ideal or biomechanically stable pattern?
Yeah, as shown today, vertical mattress is the gold standard. Maybe oblique can be acceptable to reduce the number of sutures. And one above, one below, one above, one below will be the ideal alternate ones. And placing the sutures as close to the tear as possible is another thing which we should consider.
So like any tips like how close should be the sutures, especially in this longitudinal tears?
Teaching is 3 mm away from each other, but more sutures it is better.
More and more
away
bites.
from each other.
Right. So what about the safety incisions? Like which cases we should consider putting safety incisions? We have seen Santosh sir doing that wonderfully, but we may not be same everyone.
So lateral meniscus bucket handle tear, always safety incision. Especially stitches around popliteus tendon tends to go posterolaterally and can go up to the artery or can entrap the nerve also. So safety incision, as you have shown, in that safety incision we use the biceps femoris as a landmark. Retract the biceps femoris posteriorly. So that all the neurovascular structures go below the biceps femoris. Enter the biceps femoris, you create some plane with a blunt dissection of the finger, then put your spoon, retract the lateral gastrocnemius, and then you can easily do it. Medial side, there are various options. Dr. Santosh in the morning showed there is no need of safety incision if you are using hamstring. In the afternoon live surgery, I'll be showing the safety incision on the medial side for the audience, that how to place safety incision to avoid injury to saphenous nerve.
Pratmesh sir, like for the younger starting surgeons, so is it always required?
So there are two approaches.
Yeah.
Safety incision prior to starting your surgery is a good idea, because that will actually you can put a spoon or you can put something backwards and you can take all the wires or the sutures together. So that is one. I would usually place it just posterior to the midline and more vertical. So that is it. And as Dr. Rohan said, that I will be more happy to place my on the lateral side. I would always place a safety incision. That is because that is
more chance of neurovascular injury. Santosh sir.
So whenever I place medial safety incision wise, it's going to be just behind the crest of the tibia. So your sutures might be coming posteriorly, but when you go deeper, it will be exiting the capsule much anterior. So you must keep that in mind. As you go deeper, no nick, it's going to split so that you don't cut the nerves. And
it's
you
a blunt
go,
dissection.
Dissection. And the sartorius fascia is split in line with those fibers. And the deeper layers is going to be the MCL. So your threads must be retrieved between the sartorius fascia and the capsular MCL layer. So then only your sutures will not get caught in the neurovascular structures. So retraction and tying the threads should be within those two layers.
Yes, sir. So I won't go in detail with that in view of short time. So what would be the augmentation? So when we have already done a repair and would like to augment these repairs, especially when you don't have any ACL reconstruction. So if you are doing an ACL concomitant reconstruction with the meniscal repair, I think we have enough bone marrow cells coming through the femoral tunnel and tibial tunnel. So if you are doing an isolated meniscal repair, so do you consider any of these, fibrin clot or PRP or any microfractures?
I prefer doing microfracture, little bit more saving of the fat pad and microfracture in the intercondylar notch area. I haven't used fibrin clot yet because I'm a little bit afraid taking something from the outside, putting inside, there can be issue of sterility, that's why.
We are putting meniscal transplant, sir.
So fibrin clot is a good idea, and there are not lot of new studies coming up, but I am also using it less because of more of practical issues. But what I am more focusing is on the microfracture. That is number one. The second thing that I showed in my talk also, or my surgery also, is the transtibial drilling. So whenever you drill a transtibial cell, like when you do the transtibial tunnel,
you already get that.
And that anchor will usually be a site of healing, and you can curate the area surrounding that. So that will also generate some biology and more chances of healing, specifically in the radial tear. So you can do something which is a transtibial drilling, maybe.
But issue comes with all inside. All inside repairs.
So all inside also. This is, I'm talking about all inside also. So there are two techniques. So suppose if there is a radial tear, and the radial tear is the ones in which you have a very high chances of failure and you want to augment it biologically.
Yeah.
So there are two techniques. So the first technique that I showed
especially your live surgery part where the radial tear tissue quality was poor.
So you put an anchor, you drill about 2.3 degree, 2.3 degree mm between. You put an anchor. So you drill the vascular channel, and that will help in healing, and you create the area around that. The second technique is what is described by Dr. Laprade, in which you can do a transtibial tunnels. So you do two transtibial tunnels. So there is a jig proper which comes with it, and in which you can drill two tunnels at a fixed mm distance. So you can drill your tunnel at 2 mm, 3 mm distance. Drill two tunnels, put wires around that, put your sutures, and then drill it outside on the tibial tunnel entirely. So that is called as a transtibial technique. So
it's sort of like ACL tibial avulsions one.
So what is so if you have a higher risk of lesser risk of biological healing, lesser chances of biological healing, you can do what is called as a meniscotibial fixation, and I do feel that meniscotibial fixation will increase the vascularity and chances of healing.
Santosh sir.
So without an ACL, isolated meniscus always do, as Rohan had told, marrow venting in the notch. I've used fibrin clots twice before, but it was cumbersome, and when you release the tourniquet and go and see again, it's the same picture which we see when we do our fibrin clot. But we had a discussion on this with the Indian Cartilage Society with physiology researchers in CMC Vellore.
Yes.
Basic science-wise, fibrin clot is very poor in growth factors.
Growth factors.
So their advice, do PRP, don't do a fibrin clot. PRP is much superior. So it's going to take the same time or the work, but rather do a PRP and place it there. Otherwise don't do a fibrin clot. Anyway, your native bleeding itself will be similar. So stop doing fibrin clot now.
Right. So this is the earlier one which is done with the all inside one. So I think we'll skip that. We had enough. So what would be your post-op rehab protocol in these meniscal? We do a lot of meniscal repair. So how do you follow? Because success rate or the prognosis is much more important in rehabilitating the patient in the post-op. So when do you allow them to weight bear?
So if we divide like a simple posterior horn longitudinal tear with one stitch along with ACL, then I allow weight bearing.
Full weight bearing?
Yes. If it is a large bucket handle tear.
Full weight bearing, do you brace them?
With brace, yes.
With brace, full weight bearing.
Brace, yeah.
Knee in extension.
Small tear, small stable tear.
Knee in extension.
Yes.
Okay.
Range of motion wise, except for root tear, in all the patients, at least 5 to 10 degrees of knee bending I allow to avoid some stiffness and to have some joint nutrition going. In bucket handle tear, weight bearing after 2 weeks, and more than 10 degrees or 20 degrees of knee bending after 2 weeks. Root tear, non-weight bearing for 3 weeks, and range of motion also after 3 weeks.
Pratmesh sir, your protocol.
Yeah, for me, it depends on the confidence that I get post repair. So it is little variable and it is patient specific. So the weight bearing regime may differ from 1 week in very stable patients to about 6 weeks in a root tear in which you are not very confident. If I am doing
depends on the stable construct of the repair and the tissue quality.
Yes, so if it is good, you can mobilize them early, weight bearing early. If it is not that good confidence that you get intra-op, then you mobilize them late. So for a pure root tear, I would usually mobilize weight bear after 4 to 6 weeks. Pure
4 to 6 weeks.
But if I'm doing my osteotomy like this today, so osteotomy has got a protective effect on the root healing. So in those cases, I would weight bear at around 4 weeks.
So when do you start range of motions?
Range of motion, usually most of the cases I start within a week.
Sports?
Sports after
when you allow them?
2 to 4 months.
Santosh sir.
So almost
Give a
similar.
protocol.
The tear pattern dictates the weight bearing status. If it's a radial tear, you're going to load it, you're going to have hoop stress. So there's going to be a separation of the radial tear fragment. So I'm not bold enough to load any kind of radial tears. Go away with 6 weeks of non-weight bearing for any radial tears. Even partial, I don't load it. If it's a longitudinal tear, partial weight bearing, I hope it is better because on compression, it's going to get the fragments closer. So partial weight bearing of 3 to 4 weeks. But if for range of motion, it depends on the zone. If it's the posterior part, when you have a high flexion, it's going to have a shear component. When there is a shear component, when you cross 90, there's going to be high shear in the posterior part if it's a longitudinal tear. So 90 till 4 weeks, avoid squats or high flexion for 3 months, loaded. Close chain activities should be avoided for 3 months if it's a posterior part where there is a long or bucket handle kind of a test. Sports, as I said, gradually start sports.
Praveen sir. So weight bear and when do you allow ROM?
Yeah, it depends on the root tear or the body or meniscal tear. So
if it's a body, not the root tear, only body.
Body is weight bearing, partial weight bearing, toe touch weight bearing from 4 weeks and full weight bearing after 6 weeks. And ROM for 2 weeks in extension only 10 to 20 degrees. And from 2 weeks onwards, the ROM will be increased as tolerated by the patient.
Yes, sir. Pratmesh sir, one last final question. Like you have followed up our meniscal repair cases. So what are the things to look for all the younger generations? We have done a meniscal repair. So what are the things to look for in the follow-up period? A patient has come for 4 weeks or 6 weeks down the line. So how to assess our functional repairability?
So basically you see the effusion in the knee. You see if the knee is silent. You see your scars. Occasionally, very occasionally you may get a scar which is tender. So that is one thing that you see. You may look for some paresthesias. Very occasionally these patients may complain to you of paresthesias.
So always look for any paresthesias, especially inside out.
Paresthesia specifically if you're using an inside out.
Inside out.
So these are the main things that you look forward, and obviously the objective findings and the patient comfort and the compliance is the other thing that you need to look for.
Yeah, thank you, sir. So this I kept for Santosh sir. So one last slide. They have prompt score which shows the meniscal repairability, I think. So I think sir will throw some light.
So this is a complex scoring system which helps us predict whether the meniscus is repairable or not. Like the radial tears, where it is, we have to think of repairing it because it's going to have a hoop loss. Based on the scoring system, you can decide. But this scoring system is modified now, few more factors where repairability chances are higher now. So
why you modified, sir? Like
because we are repairing more now. So
failures are more.
Yeah, so this is modified.
Okay.
It's just a guide to.
So what is your best score to repair in this? So when do you repair according to this score? Like how much points?
If the score is lower, you repair it.
Okay.
So higher the
Threshold,
score goes,
threshold score.
Threshold around 6 and 7 was the initial thing, but it is coming going higher.
No.
Score is going higher now because we know it's healing.
Yeah, thank you, sir. Thank you so much. Thank all the panelists, and also once again, thank you so much.
That was a wonderful panel discussion. So we'll just have 3 small short talks. Post that, we'll break for lunch.
So I think most of the tips and tricks and indication techniques of meniscus root repair have been discussed, and in live surgery also Prathamesh sir showed us the technique of root repair. So I'll not go in much detail, go very fast. There is a Laperout's classification of the root tear. It has been extended also, but the basic classification was type 1 to 5. Type 1 is a partial root tear, type 2 is complete, type 3 having root tear with bucket handle tear, type 4 is a oblique complex tear, and type 5 is with a bony avulsion. The major mistake that can happen during the root repair is a non-anatomical placement of the root. So there is a area that is defined by Laperout's cadaveric dissection. There is a middle meniscus posterior root area, and there is a lateral meniscus posterior root area. So just around 1 centimeter behind the middle tibial eminence is the root, and just anterior to the shiny white fibers. This shiny white fibers is a very important landmark during the surgery. So there are various studies. There's conflicting results. Some says that suture anchor is better, some says tibial pullout is better, but eventually long term the result wise both are same. But most of the studies says that initial cycling loading wise suture anchor has a better stiffness of the construct compared to the tibial pullout. And now we have the RSA, that is the reverse suture anchor that we could see in the live surgery, that is the reverse suture anchor. So in short term wise, all the studies says that the reverse suture anchor has the more cycling loading of the suture anchor, but long term clinical study says both have the higher failure load. So especially in this, when we are doing HTO with ACL or another cruciate ligament reconstruction with ACL, there is a chances of tunnel collision. So in this case, we are planning HTO along with the root repair. And as you can see, there is around meniscus loss here. The root is, because of the chronicity, root is not there. So just in rotator cuff principle, we do sometimes medialized cuff repair to avoid tension. Here the placement of the tunnel is also little bit more medialized to avoid too much of tension on the root. In this case, we are planning HTO also, so root fix anchor by Osteocare was used. The same way that was demonstrated by Prathamesh sir. And this is a number 0 fiber wire, low profile, don't have too big knots inside. And prior to doing root repair, we do incision of the HTO, release the superficial MCL to get more opening of the joint, and step by step passing of the suture using the suture cannula, just that we use for the shoulder arthroscopy. These small instruments like suture retriever, knot pusher, knee scorpions, or you can have the disposable, that first pass also, because knee scorpion sometimes in the government hospital setup becomes a little bit expensive, so you can have the disposable first pass. If you have enough joint space, you can use the first pass of the shoulder scopy also, or the first pass mini is also available. Now there are various techniques of using this. In this case, we have the meniscus quality was not that bad, so we just use the simple stitches. But you can have a ripstop or modified Mason Allen type of stitch also. So what is modified Mason Allen? In one, you have horizontal mattress, and another will be the vertical mattress. So the horizontal mattress one will prevent the cut through of the vertical mattress. So that will act as a ripstop. Here we just took 2 simple stitches because the quality of the remaining meniscus tissue was not bad. Sometimes the original technique described by the Laperout was the suture pull-out technique, where you take a number 2 fiber wire with your scorpion device, take a luggage tag stitches that you cinch the meniscus though it doesn't cut through. You can use a fiber tape also here. So 2 different colors stitches are taken, and with your meniscus root repair, or in initial days when there was no root repair jig, you use your ACL tibial tunnel jig. You scope out here, denude the cartilage, prepare the footprint. This is the multi-use jig by the Osteocare. Even their Osteocare's ACL jig is also compatible with the root repair like this. You pass your beach pin over rim with a 4.5 cannulated rimmer, then suture shuttling device from the outer tibial tunnel, and then shuttle your stitches. So this is relatively technically less challenging than the root fix. This is a simple suture pull out as you do for ACL avulsion, and then use your endo button outside to tighten. But here there is a chances of tunnel collision if you are doing this with ACL reconstruction or high tibial osteotomy. So nowadays we prefer more and more root fix anchored devices if we are planning this along with our high tibial osteotomy. Here the fixation of the root is away from its footprint. So the button is lying outside the cortex. So there is a long distance the fiber wire has to travel. So the higher there is chances of high loosening in the initial days. So you need to protect this device. So as per the in vitro studies, this suture pull out technique in initial phase when the meniscus healing has not happened, there are high chances of loosening, while the root is just at the footprint and the distance traveled by the fiber wire is significantly less. So the initial phase when the meniscus healing has not happened, the failure rate is very less. So whatever technique you prefer, you need to follow the guidelines that there should be tension free repair, proper footprint preparation, and the most important thing is alignment correction. Most of the cases, if you see, the overlying cartilage is very bad. So if you think that cartilage is bad, you need to have that proper correction of the alignment for better healing. Thank you.
Thank you, Dr. Rohan. That was a nice demonstration of the root repair. I have a small quick question to Dr. Rohan. If you are using outside in technique, you are fixing the using a button outside the tibia. What is the position of the knee that you are going to keep while doing the final fixation to avoid the loosening of the knot?
So 30 degrees.
A 30 degree flexion.
Yes.
You do the final fixation.
Yes. But if the meniscus is attached on its isometric point, it doesn't matter in what degree you are tightening. But in above 90 degree, there is high shear force on the posterior aspect and the root will be overloaded. So anything between 0 to 90 is fine, but to be on a safer side, 30 degrees.
Okay. Thank you. And if there is already a cartilage damage at the root area, still the fixing helps? Does it help in
so as per Dr. Robert Laprat's study, cartilage ICRS classification grade 1 and 2 is an ideal candidate for root repair. Grade 3 and 4 isolated root repair will not help. Either you do HTO, means you do HTO plus or minus root repair. But if you are arthroscopy surgeon, if you have armamentarium, you are equipped to do root repair, it is better to combine HTO with root repair. There are many surgeons who are not into arthroscopy, they just do HTO, they are also getting good result. But there is no harm of doing root repair with HTO in grade 3 and grade 4 arthritis. But grade 3, grade 4, there is no indication of isolated root repair.
Thank you, Doctor. That was a good talk. May I now request Dr. K.S. Praveen Kumar to give his talk on root tears, how important is it?
Good afternoon, everyone. Thank you very much for giving me the opportunity. I thank Srinivas and SRS team. Congratulations to them, and it's a very good scientific program. So, this is almost a repetition, but I want to talk about more on the clinical points of root tears and how important it is. That's good. So let us go and see. Coming to the anatomy, the medial meniscus posterior root attachment is 9.6 millimeter posterior and 0.7 millimeter lateral to the medial tibial eminence, and 8.2 millimeter directly anterior to the most proximal aspect of the PCL tibial attachment point. Why anatomy is more important is, while you are reconstructing the root, if you just deviate 3 millimeters away from the native anatomy, then there will be 25% of increase in contact pressures and loss of hoop stresses, and then again joint is going into arthrosis. So the native anatomy is very much important here. Even mere 3 millimeters of deviation from this is detrimental to the joint. So again, the lateral meniscus is 12.7 millimeters directly anterior to the most proximal aspect of the PCL tibial attachment. Clinically, the anatomy is very important. You go to this is the medial meniscus anterior root attachment. This is more anterior than the lateral meniscus. Clinically, this is more important is because it is at risk for intramedullary nailing in tibial fractures. When your entry point is more anterior and into the joint, if any surgeon goes into the joint, then this medial meniscus anterior root tear is more common in intramedullary nailing. So be cautious about that when you are doing with the trauma surgeon going on the intramedullary nailing. So, and lateral meniscus anterior root tear. So this is again is a very good significance in maintaining the joint stability. So it is more iatrogenic, more risk is at during ACL tibial drilling. If you go a little bit laterally, the ACL footprint is very close by to the anterior root of the lateral meniscus. If little lateral to the ACL native footprint, then it is more risk of injuring the anterior horn of the lateral meniscus. So if that goes, again the patient will come with pain in extension, pain in while walking and all. So beware of the anatomy and then avoid injuring the lateral meniscus anterior horn while doing ACL tibial tunnel reaming. So this is the importance of the anatomy. So because therefore anatomic repair is necessary to decrease detrimental factors and progression of osteoarthritis. Mere deviation of 3 to 5 mm from the native site substantially increased mean contact pressures. So meniscal roots have important function to convert axial tibial loads into hoop stresses. So these are all already repeated. So increased contact pressure will cause early osteoarthritis. So lateral meniscus posterior root has a significance. It has a significant role in prevention of the anterior tibial translation and during pivoting activities. Grade 3 Latchman and grade 3 pivot shift in ACL, you always should suspect lateral posterior root tears. And because they sometimes coexist and the stability will be increased along with the ACL reconstruction, we have to address these lateral meniscus posterior root tears also. So as a definition, it is 1 centimeters from the meniscal root attachment. The meniscal root tears are defined. So most cases it is 70% of the medial posterior root tears and in degenerative knees without a specific injury event or a minor traumatic event such as squatting. Patient will come with a small popping out sound and then trivial trauma by sitting in a squatting position will get a pain. And then there is increased risk of medial meniscus tears. If you overall see, it is 10 to 21% is the medial meniscus posterior root tear. So diagnosis, clinical examination, joint line tenderness on the medial side, and physical examination, pain in full flexion. Patient will come with locking episodes, not like locking episodes. They come with a popping sound. Sometimes the pain, even without evident trauma also they will come. These are all the symptoms for the degenerative tears. It's not unlike traumatic tears. Degenerative tear will come with subtle trauma. There is no much history on the trauma. So the risk factors for medial meniscus posterior root tear are the varus alignment, increased age, high body mass index and female sex. So the classification has already been described, type 1, type 2 and type 3, type 4, type 5 by the Laprade and et al. In 2015. So MRI, these are the 3 important signs in the MRI which we have to pick up. One is the radial tear where linear high signal intensity in the axial plane and there is a truncation sign and there is a ghost sign in the sagittal plane. So as all aware, non-operative no role, but in degenerative, severely degenerative tears, there may be non-operative thing, but meniscectomy, more chance of osteoarthritis progression. Suture anchor repair that we have seen already, transtibial pull-out repair also has been, Rohan sir has been clearly shown. So this is one case example. This is a 42 years old female, pain and difficulty in walking, medial side more pain. MRI has shown medial joint OA and medial posterior root tear. The plan is HTO with root repair because she is very young and 42 years. So this is a video. you can see there is a grade 3-4 arthritis, and there is a medial meniscus root tear. So again, I usually take one fiber wire and one fiber tape, and transtibial tunnel pull-out technique I use, and fix with a suture button. So this is the one. And finally, you can see, yeah, that is the repair. You can give a stable construct. Yeah, after tightening, that will be a stable construct. So this is the post-op picture of the HTO. So in conclusion, posterior horn medial meniscal root avulsion leads to deleterious alteration of loading profiles of the medial joint compartment, resulting in loss of hoop stresses and meniscus extrusion and abnormal loading of the joint and early knee medial compartment degenerative changes. That's why root tears repairs are very important, that will avoid degenerative changes or osteoarthritis progression in patients. Thank you very much.
That was a vivid presentation by Dr. Praveen. Thank you, Dr. Praveen. Before we quickly break for lunch, we have the last talk by Dr. Suryavardhan on the concept of meniscus centralization.
My topic is concept of meniscus centralization. Am I audible? Yes. Yeah, meniscus centralization. The first question is, where do we require the meniscus centralization? So in case of meniscal extrusion, we need a meniscus centralization. The next question is centralization. So where do we need this meniscus centralization? The answer is in case of meniscal extrusion, we need this. So the next slide. So next question is what is meniscal extrusion? That is a displacement of meniscus outwards from the medial tibial rim. So let me talk about a few biomechanics of knee joint. So while walking, what happened now? The meniscus is compressed between tibial and femoral condyles, and the meniscus is pushed outwards. To prevent this, we have a strong anterior and posterior connection, that is anterior root and posterior root. So because of this, the compressive forces will convert into a circumferential tensile forces, that is called hoop stresses. Whenever we have a root tear, that is a posterior root tear, these hoop stresses will decreases. There is a more contact pressure between your femoral and tibial condyles. So finally the articular cartilage will damage more fastly and eventually osteoarthritis. So the only root tear is not sufficient to prevent the arthritis. Along with that, we need an additional procedure, that is centralization stitch. That is our topic. This is all we discussed. So root tear along with the centralization is mandatory nowadays. So where do we see this meniscal extrusion? There are three main causes, that is posterior root tears and radial tears and degenerative posterior horn tears. And there are various techniques to address the extrusion. We can use either transtibial pull-out technique or a suture anchor or a simple all-inside suture anchors also. So main indication is isolated root tears or radial tears or the posterior horn with extrusion greater than 3 to 5 mm in grade 1 or 2 osteoarthritis. If it is a grade 3 and 4, this procedure is contraindicated. This is an overview. The first step is a preoperative planning. We should take at least a scanogram, long-standing X-rays to see for the varus alignment and MRI to look for the root tears and meniscal extrusion. So we have a criteria like more than 3 mm displacement of the meniscus away from the tibial rim, then we can call it as a meniscal extrusion. And we have an entity like a physiological extrusion also, that is less than 2 mm. We have a lot of grading systems also for this. But finally, anything beyond greater than 3 mm displacement, we can consider a centralization stitch. So patient positioning is just like your ACL, supine, lateral thigh support, 90 degrees flexion. So portals are, one more important portal is there. So the first portal is like high antero lateral portal, that is viewing portal. And this is low anteromedial portal, that is working portal. And the one more portal is called, this is mid-medial portal. This is important for the placement of the anchor. So that is it. So always do pike resting while doing any kind of procedure in the medial compartment. This will release more space to negotiate your instruments, and it prevents the cartilage scuffing and the meniscal injury also. We have various techniques to centralization. One is a transtibial pullout, and other one is a meniscal simple anchors. Before putting your mid-medial portal, always check with your spinal needle. This gives exact location of your mid-medial portal along with your angle and trajectory of your anchor placement also. Because if you don't put correctly the mid-medial portal, then there is a lot of chances of articular damage and meniscus damage also. So then create a mid-medial portal with a 11 blade. Put your ankle at the rim of the medial tibial plateau and take a straight lasso and take a capsular bites underneath, and you can retrieve the lasso loop into the medial portal, anteromedial portal along with a suture. I can shuttle it to mid-medial portal and repeat the same step with all the remaining sutures and tie it outside the capsule. And before knot tying, make sure that there won't be any tangling of the sutures. And one more technique is a transtibial puller technique. In this, submeniscal portal is important. So this is how we can use ACL tibial jig or root repair jigs to tunnel from the anteromedial cortex of the tibia to the centralization portal. Take spinal needles with the loops, 2 spinal needles, and the final construct will be like one loop will go into the other loop, and it should be like this. And those limbs should be shuttled back to the anteromedial portal, anteromedial cortex through this loop. Finally, this is the construct, right? So the main principle is to bring it back to the normal place so that we can restore the hoop stresses, so that we can prevent articular damage and eventually osteoarthritis. That's it. The post-op rehab is same for just like your 4 weeks of immobilization. So in conclusion, arthroscopic root repair alone is not adequate for the to restore the hoop stresses. Along with that, we need a centralization stitch. If we combine both the procedures, so the long-term results are very good. That's it. Thank you.
Thank you, Surya.
Sir, if you want to do the lateral meniscus repair, you can continue.
As I mentioned, I'll do lateral meniscus repair after femoral tunnel placement.
Okay, then we'll get back to you at that time, sir.
Yes, okay.
Okay. So we'll continue with the session, sir. I would like to call Dr. Chandrasekhar Naik, sir, to moderate the session, and also Gangaraju, sir. So SAR will be talking on two topics, meniscal root reconstruction, when and how, and also when do I add HTO to my root repair, as Ramanmurthy sir has been engaged with some emergency, so he's not able to deliver his talk today.
Hello everybody. So meniscus root, we have been discussing it from the morning. We have seen in the live surgery as well. So it has been a very new concept, and what we have learned is that meniscus root is one of the main culprit. Meniscus root tears are the main culprit for an accelerated progress of osteoarthritis. So supposedly, if you are seeing any patient who is having a very rapid onset or rapid development of osteoarthritis, the meniscus root tear is the culprit or is the reason most of the times. And when we do meniscus root repairs, the results are good, but we are not able to achieve an excellent result in most of these cases. So transtibial root repair is a good technique, but there is a good repair, but it does not leads to an excellent success rate. Root repair with anchor, the root fix technique which we showed in the live surgery, also is a good technique. It has a better outcomes than the transtibial technique. But yes, we have seen progression after the root repair with root fix as well. Now, to counter that and to improve the results from that, the newer thing that is to add biology to the root repairs, and this is called as what is called as a root reconstruction. It is supposed to have a better healing rate, and it is specifically indicated in chronic neglected cases, specifically when the patient is having a good alignment, or if the patient is not consenting to do a HTO. So this is how we do it. So this is a patient which has a root tear which is very bad. It's a chronic tear. It has been untreated for a long period of time, and we can see that the meniscus root is not only torn, but it is also retracted medially about a centimeter. And these kind of tears are usually poor prognostic tears, and whenever you repair them, you will not be able to achieve a good or an excellent result with the classical meniscus root repair techniques. So what we do here is we do a procedure which is called as a meniscus root reconstruction. We use a gracilis graft. We harvest the gracilis, make about 6 to 7 centimeters of the graft. Both the ends of the graft are prepared, and then there is a special device. This device is from Osteocare. This is called as a meniscus root dilator. So what it does is it dilates the area from where we want to pass the gracilis, and here we have to pass it on the back. So on the meniscocapsular junction, we take a bite with a first pass mini. We pass the meniscus root dilator. It is available in two sizes, 2.5 millimeters and 3 millimeters. And over that, we will load the gracilis. So here we see that the gracilis is going in. So this dilator has a loop on the back, and with that loop, the gracilis is pulled. At the midway, we mark with a vicryl. So we know that we have gone up to the half mark. So this tendon is pulled. We identify the vicryl at the center point. So it should be at the meniscocapsular junction. Now we have two limbs of the graft, which we can see clearly. After that, we make the transtibial tunnel like you do in a transtibial root repair. We dilate it with a 6 millimeter of reamer. So we make a tunnel as we make in the transtibial technique. So we make a transtibial drill. You can see that hole right there. We over drill it with about 6 millimeter of the reamer. You can use 5.5 or 6, that is perfectly fine. You prepare it with the curette nearby, and then you take out a wire through that tunnel, just as you do in your transtibial root repair. And with that wire, you shuttle both of the ends of the graft into the tunnel per se. So you take it out, the needle is taken out, you hold it up, take the chia out, put the looping suture onto that, and then this will pull both of the graft into the tunnel. So when you pull it, both of the parts of the graft will be pulled into the tunnel as such. Okay, so you can see now that both the ends of the gracilis graft are now pulled up into the tunnel. You tighten it, take it about 30 to 40 degrees of flexion. You have to be careful here that all the 4 sutures, so there should not be any knot entanglement. So when you pull it, everything goes in. Okay, so when you pull, this will become tight and tensioned. So this will add biology to your root repair. So when you pull it, whole of the meniscus root along with the gracilis is fixed it onto its place, and after that you can use either aperture fixation using a screw, or you can use it later on. And you can see that there is very good fibrin layer which is deposited in the end. So here this is the final picture of our meniscus root reconstruction. So this is a prospective technique. What we have seen is that this technique gives a better biological healing rates. So the mandatory device is a root dilator. As I told you, it is available in 2 sizes, 2.5 millimeters and 3 millimeters. It leads to a sequential dilation, because the most difficult step in this particular procedure is to do a sequential dilation. And the complete healing rate, if you see in the post-op MRI, it increases to about 80% from like 50% which we see in the transtibial root repair. So with MRI healing, we can see a drastic difference in biological healing rate if we are using meniscus root reconstruction with a graft. So better knee outcomes, you get a better Lisholmes, better IKDC scores. There are now a few studies which have been published on that. You can see post-op images, you can see a very good healing of the meniscus root as well. Now this is about the second part of my talk, the present algorithm in my practice. So if the patient is, you are seeing an acute patient with a root tear in a young individual in a traumatic setting, you can straight away go ahead and do a root repair with a root fix and just forget it. Just do your root repair nicely, and that you usually work. If the patient does not is presenting you in a chronic aspect, then, and if he does not have a varus, I would do a meniscus root reconstruction. If a chronic setting patient has a varus along with a root tear, I would do a meniscus root repair with root fix along with a high tibial osteotomy, what we have seen in the live surgery today. So significant varus, that is the Fujisawa line less than 40%, or MPTA when it is decreased significantly, is usually the indication of my practice to add an HTO to the root repair. So HTO is protective to the root repair, because if you do HTO, you reduce the load on the meniscus root. And as I told you, when I do an HTO, I can mobilize my patient faster, and I can start an early weight bearing as compared to my solitary root repair patients. Now just basics of HTO. You can do HTO in many ways, like open wedge, closed wedge, dome osteotomy, hemicallocytosis. There are many ways. But when we are talking about the ligament part and the correction of the root part, open wedge osteotomy are better as far as the closed wedge osteotomy, because they tension the ligaments, and hence as far as the knee preservation things goes, the medialing open wedge osteotomy is currently the recommended one. So there can be some contraindications. If the age is more, there is lateral sided osteoarthritis, the range of motion is less, the flexion contracture is more, there is lateral tibial subluxation of more than a centimeter. So most of these cases we would do a high tibial osteotomy, and that too of a medial opening wedge type. So there is a phenomenon called as a Fujisawa point, and you should be aiming of a Fujisawa point approximately at about 50 to 60% of the center. So the traditionally speaking, they were keeping it around 66%. Then they reduced to around 62.5%. Now it is approximately on the lateral tibial spine, that is around 60%. So you have to correct the axis approximately at the level of 60% on the lateral tibial spine. You don't have to go more lateral, because if you are repairing the root, you are actually creating a good alignment for the root to heal, and you don't want to overcorrect the knee in those circumstances. So this is the scanogram that we do in all the cases, and this is how we calculate the angle. Usually 1 degree of correction is equal to 1 mm of the wedge, but this is true only when the tibial diameter is about 57 millimeters. Now this is the surgical technique, we have discussed it in detail. You can use the plate we use, that is the standard plate, or now there are anatomical plates which are also available. So these are the anatomical plates that are available. These are the intra-op images. These are the post-op X-rays. And something about the wedges. So usually if you are doing more than 10 to 12 millimeter of correction, you may try to add a bone graft or a bone substitute for a better healing and a faster rehab. As I told you, usually the non-weight bearing is usually recommended for 6 to 8 weeks. But nowadays we are doing an accelerated rehab. So my patients of HTO with a root repair, usually we mobilize them weight bearing at about a month. So 1 month of the procedure, they are allowed to bear the weight and walk.
Good afternoon, everyone. Today I'm going to show how I plan my osteotomy in a medial compartment osteoarthritis or medial meniscus root tears if there is a varus component. So as for any case, we'll take the history, like you specifically ask for the medial knee pain, and you ask the patient to point to the knee where she has the pain, when most of the times they show it on the medial side of the knee. So when they walk to your OPD room, then you see the gait, do they have the varus thrust or not? And then in the examination part, obviously you check for varus and check for medial joint line tenderness, which is more specific, and McMurray if the patient can bear the pain. So as usual, we'll get the X-rays like AP standing, lateral and skyline. Skyline may help in your patellofemoral pain. So, and I do get MRI knee. In a varus knee, it helps like in identifying the root tear, if there is some other meniscus tear, or if the intactness of the lateral meniscus also can be seen, because you are going to offload the medial compartment and you are going to load the lateral compartment. So it is important to check for the lateral meniscus intactness on an MRI. So some people do HTOs without getting the MRI also, because some people believe just a root repair no, just a HTO will help without a root repair. So I don't believe in that. So I get an MRI for all cases of varus knees to check the meniscal status and condyle status. And the most important thing in the planning comes the scanogram, which is a full length weight bearing standing X-ray. And when you get the X-ray, see how do you get the scanogram is really important, because all people may not have the resources to get an ideal scanogram. So what we do, see what in the picture you can see the person there. So this is the latest one, so it's very easy to get this scanogram done. But when the resources are not there, this is what you want to do. You take a 51-inch cassette or stack the cassettes one by one and use a steel ball like in known diameter. You get a bearing anywhere. So you just take a bearing which is of known diameter and you place it over the knee or thigh. Then you keep the patient away from the source, X-ray projector, 10 feet away, and give a radiation of 10 kV or something. So important thing here is how you position the patient, which is to face the patella forward, which is done by doing a 15 degree of internal rotation at the foot. So and make sure clinically, ideally this is not the way you have to expose the patient. Mark his ASIS, make sure it's at the same level. If it is not, you correct the limb length to get the ASIS at the same level. So once you get the scanogram, do check some of the points. Like as I said, from the top to bottom, you check the ASIS at the same level or not. And then you come to the patella. See, the patella is centered in the center of the knee. And you come down, you can see the tibia, fibula is getting overlapped by the tibia, at least the 1/3 part of it, medial part of it. And you can see the fibula slightly at the back of the tibia. This is how it is when you do in 15 degree internal rotation, kind of a mortise view. And don't forget, you need to get a monopedal lateral scanogram also. You need to find out the tibial slope, okay? Because in ACLs, if you have high slopes, you may have to do a deflection osteotomy, or if you're doing a HTO with an ACL also, you need to correct the posterior slope by distracting more in the posterior cortex. So these are the things you keep in mind once you get an X-ray scanogram. Make sure it is done properly. If not, get an scanogram again. So a properly done scanogram looks like this. Even though looks like this, you have to have a calibrator to get this steel ball calibrated. You can see the medial compartment, something like a KL2 knee. So in the Miniachi method, we are going to do this in the Miniachi method, which is most commonly done. So in the next slides, I'll take you through how it is done. So you draw the weight bearing line from the hip center to the ankle center. As you can see, that has crossed way away from the middle, inside, not even in the joint, it's inside. So which says it's a significant varus. So then you need to find out where the varus is. So first thing you do, draw your MPTA, which is roughly 78 here, which is far way less than what it has to be, which is 87 roughly. So next thing, go take your LDFA, which is 89. 88 is a regular one, it's normal. Then take joint line congruency angle, which is 3 degrees here, 1 degree more than the normal. And then measure your Mikulic's line, which came to be 719, and draw another line where you want to. Like Sir said, it's going through your lateral spine, and it should be the same length of the previous line. Once you've done that, then mark your hinge point, which is at the lateral tibial cortex, at the head of the fibula. Once you mark your hinge point, that is where you're going to distract your osteotomy. So after that, what you do is you connect these 2 points, the distal ankle and the presumed weight-bearing line, to the hinge point. So whatever angle that makes, we call it as alpha. From now, we will calculate the deformity from that angle. So this is how the calculation goes. As you can see, the alpha minus JLCA that we got around 3 degree, right? And what was alpha? It was 17 degree. Minus JLCA 3 degree and minus 2. Why we do minus 2 here is because this is a normal JLCA. So we want to take out the normal CA. We're going to see where the excess intra-articular varus is. So which is more of 1 degree. So we're going to minus that from the alpha angle because we are not correcting the intra-articular part. So what angulation? The final degree of correction will be 16 degrees for this case. I hope you got the calculation. So once you got that calculation, how much degree you want to correct, then again you go to the hinge point which I have marked here on the lateral tibial cortex. Then you cut. This is done on a software. So this is how we cut it. Cut the scanogram. So once you done the cutting, then you're going to distract the osteotomy to the desired angle of correction, which he had got as 16 degree. So once you have corrected it, then you got to draw the line which you are desired for. So previously we planned a line to come here, and osteotomy is exactly at that point. So we are very precise so far. So again, one more thing, in a closed wedge osteotomy, you need to take a correct amount of wedge because you can't redo the osteotomy. But in open wedge osteotomy, you can distract the joint how much ever you want. So in those cases, you can distract it on table and get your correct alignment. So it may not be so significant here, wedge. You can do it on the table. And how to calculate the wedge? Once you have, this is the importance of the steel ball we are using for. So the steel ball of known diameter, which I use here, is 3 centimeter. This is the calibrator. I know how much. Obviously, this is a downsized X-ray. You don't get the zero size X-ray, which you used to do in our PG days. So once you have the calibrator, you will get the known diameter. Then you know the wedge length of the wedge you are going to take out. I mean, in the open osteotomy, you're going to how much you open, you will know precisely in millimeter. So this is how we do a HTO. All of you have in mind that we have to do a HTO for a varus knee. Need not be every time. So let's see how it is. So this is again, look at the knee. Alignment goes varus, isn't it? So again we do the same homework here. Draw the weight bearing line. Then calculate the MPTA. Check it is 88. So 88, is it normal or not? It is normal, right? So what here, can we do a HTO here? Definitely not. Okay. if you are doing a HTO for this case, you are putting the joint line in oblique way. Then it's going to develop shear forces, which will in fact counterproductive. So you don't going to do that. So what do we do? We go further and take our LDFA, which came to be 93, which is way more than what it has to be. So you already know the answer, where the correction is going to be in the femur. So how we go, again, we don't miss these things. We have to get the JLCA for these cases also, which is 5 degree. So there is so much component of varus inside the joint itself. So again, you measure the weight bearing line. Then it's we're just going to flip what we have done for HTO. We have done from top to bottom here. We're going to do bottom to top calculation here. So the weight bearing line as it is goes from hip to ankle. As you can see, it's going medial to the knee, okay, and inside the knee. So you will draw a line from the ankle, says of same length, to the point where we want to achieve a correction. That is going to be our lateral tibial spine. So once you do that, again, this hinge point, where do we develop the hinge point for these cases? On top of the medial femoral condyle. This is the hinge point for us. It will be at the splay of the tibia, where it becomes the condyle. So again, we do the same thing. From that hinge point, you draw a line to the all 2 points we have taken before. Then you will get the alpha. Alpha we got as 14. So this, why it is 11? Again, we will do the same calculation. JLCA, so alpha is 14. JLCA minus 5 degree, 5 degree minus JLCA is 3 degree. So you minus the 3 degree, that's 11. So we're going to remove a 11 degree wedge. It may not be 11 centimeter as Pratesh sir was explaining. So only if your tibial diameter is 57. So this is the where the software helps, because you in a closed wedge osteotomy you cannot attempt an osteotomy and redo the cuts. It's very difficult on the table. So what you precisely calculate the wedge, go ahead, do it. You don't have to look back. See, so again we cut the X-ray like this, then we close that wedge. How much? 9 mm. That's what we planned for. Once you close the wedge, again you check the weight bearing line. Is it going to the place where you desired it? So if it is going, you are good. So if you can see these kind of cases, you get a very good correction. This is the distal femur osteotomy. We have done a meniscal root repair along with it. This is not HTO with root repair. We can do a DFO with root repair also, because we are correcting the deformity where it has to be corrected. And see, the joint space has opened immediately. So take home message, we do have to, a lot of cases are HTO with root repair, don't disagree with that, but correction has to be done where it is, where the deformity lies, and precision planning will give you the outstanding outcomes. Thank you very much.
Congrats, Ramraj, well explained.
Thanks.
All these this one. Next, any questions from audience? Okay, next talk. Panel.
We'll have a panel discussion on management of root tears. So I would like to invite the panelists, Dr. Prathamesh sir, Dr. Sridhar sir, Dr. Ashish sir, Dr. Harish, and Dr. Surya, and Dr. Praveen sir will be moderating the session.
So only one case for discussion for today. So this is a 30-year-old male, had a twisting injury, grade 3 pivot, and MRI, I don't have MRI images, I will show the arthroscopy image. MRI showed ACL complete tear with the lateral meniscus posterior horn tear, with substance loss of 9 millimeter to 10 millimeter. There is almost a gap of 1 centimeter there. So what are the options now? What is the plan, sir? Prathamesh sir, from you.
usually, if you have a substance loss, this is almost equivalent to a radial tear, and it tends to progress with time, and the patient will tend to be in a progressive painful state with time. So one is you can do a closure under a little more tension. You can do a side-to-side repair with a anchor that I told you. So root fix anchor is one option. You put an anchor on the tibia. Put an anchor into the tibia and do a side-to-side repair. Adding biology will be the second thing. So the thing which is described is you can use part of the gracilis and stitch it on both the sides. And a very aggressive option will be to do a meniscus transplant maybe. So, but I would probably do a meniscotibial repair with an anchor for most of my cases, and occasionally I may think of doing a graft with maybe a gracilis graft or something like that.
Sridhar.
Yes, sir. Maybe simple way what sir said. Maybe root fix anchor in the center of the defect and tie both side to side repair so that you won't allow that to progress there.
So if we are unable to go to that, then the repair is not good, then what would be the plan B?
It will be reconstruction only.
With the gracilis?
Yeah.
Or you can use a meniscus soft tissue allograft which is not available.
Yes.
So that is it.
Okay, so plan A, as sir said, I did a small technique of putting a leg in high flexion of 120 to 130 degrees, like cross-legged, completely like this, and then I could achieve some approximation, and after that I took bites, lateral end-to-end repair. So that is the thing. After complete deep flexion, I could see some approximation there. Then I took bites. I did an end-to-end repair. And then tied the knots. And this construct is being supported with all inside device also. With that, so it's okay, good. It's gone. Whatever. End-to-end repair with Fast Fix Mini, supported with all inside device. Sir, after this repair, rehab protocol after this repair.
I would keep them non-weight bearing because this is a radial sort of a tear and we have done a side-to-side repair. So I would 1.5 months, approximately 6 weeks of non-weight bearing is essential. You can start range of motion is about 2 weeks of time. But you need to protect this, and these are bound to fail because you have to be extra cautious in these sort of.
Chance of re-tears are more with this kind of tears. Okay.
Radial tears, and specifically in my personal practice, I have seen more problems with lateral meniscus as compared to middle meniscus. So that's also one thing which you have to keep in mind.
Any augmentation with, because grade 3 pivot is there, LET, would you advise?
So if there is a high grade pivot, you can add LET for sure.
Right. So because high grade pivot can be with the lateral meniscus itself.
Yes, yes. But you have to see after you do it, do ACL.
Yes.
And then you can just check if there is a pivot which is remaining.
Remaining,
you
yes.
might consider LET.
That's good.
The only negative part with LET is occasionally LET, if you put it under over tension, it may cause the lateral sided pain. So we have seen some cases. So if the patient is having a lateral meniscus tear, my threshold of doing LET is little less as compared to a medial meniscus tear. Because you do it on the lateral side, and lateral sided bursitis occasionally can lead to pain. So that is one thing that you should keep in mind. Even valgus knee, it is said that you don't do it LET. So ideally you should not do it in valgus knee, not with a significant lateral meniscus problems. So it may over constrain the lateral compartment.
Yeah. In this case, even without putting the tibial side anchor, I could able to achieve with all inside device and then this thing. And then after that, after completing the ACL, I went in and checked again. After doing cycling and all, it is stable enough. So, right. Thank you, sir. We'll go for the next.
Praveen sir.
Now I request Dr. Khan sir to give his lecture on meniscal transplantation. Where do we stand?
Good afternoon, everyone. I'm Dr. Abdul Khan. I'm going to talk about meniscal transplantation. Where do we stand? Okay. So, as you know, meniscal allograft transplantation has become the state-of-the-art treatment for young symptomatic meniscectomy patients. Okay, we want to restore the joint contact pressures and delay the progression of OA. Okay. So I'm going to talk about where do we stand for the indications, sizing, graft processing, how do we fix it, rehabilitation and outcomes. Okay. Indications, as I told you, symptomatic meniscal deficiency without any advanced OI changes. Okay. So any concurrent pathology like any malalignment or ligament deficiency has to be dealt before or at the same time. Okay. Contraindications, we don't want to do it in advanced OA, septic arthritis, obesity, skeletal immaturity, synovial disease. So just a paper with Lee et al. Regarding the indications, he divided into three categories. Ideal indication where there is no or low grade chondral lesion, and relative indication is where there is a high grade lesion on either side, not on both sides. High grade lesion on both sides is a salvage indication. Okay, so you can see the estimated cumulative survival was very low for salvage group, 62% at 5 years compared to the other two, which are well above 90%. Okay, so we got the International Meniscus Reconstruction Experts Forum, IMREF, which has published a consistent statement, which is published in 2017. Okay, so they had given a lot of guidelines how to do it and when to do it. Okay, so basically the interesting thing there is 18% of them answered that they would do even in unsymptomatic patients for lateral meniscus. Okay, so decision when to do is on a case by case basis. Okay, so we usually don't have an ideal patient always. So there is a chondral lesion. So we have to explain to the patient the failure risk when we do it. Okay, and any other associated procedures should be done at the same time or before. Okay, Sizing of the graft, we want it within 10%, okay? So oversized or undersized have their own set of problems. So gold standard is the Pollard method to see the size of the meniscal graft, okay? So, but now here 3D CT is now widely used these days, okay? So McConaughey in his study has shown that if it's within 5 mm, 100% of the time CT is correct, okay? And radiograph is about 76.5. MRI is not predictable, is unreliable. It may underestimate the real size. Okay, Pollard method, I'm not going to go into that, but I kept a couple of photographs for you to see. But CD is widely used these days, okay? Processing, like bone grafts, we got fresh frozen and freeze dried. We know the pros and cons of both of them, okay? No one has absolute superiority of one method or the other. We got a few papers there regarding this. We don't want irradiation because it might affect the biomechanical properties, okay? Fixation, we got 3 methods commonly used. Suture only, we got bone fixation, double plug and keyhole, okay? Suture only, we fix it with sutures, and the roots are fixed with transtibial suture technique. Double plug is where the graft is prepared with a 7 mm bone plug on either sides of the root, and which is fixed into about 8 mm of the bone defect in the tibia, and they're fixed with sutures. And the remaining meniscus is fixed with suture, as you can see in the diagram below. Keyhole is usually used in the lateral meniscus, where the 10 mm bone bridge is used, which connects the anterior and posterior horn. It's very useful in the lateral meniscus because they're very close by, and double plug may fail because the tunnels are close by, okay? So the contact mechanics of bone plug are definitely better biomechanically as per the studies. Again, under dynamic loading, transosseous fixation, both methods are better compared to suture only. Having said that, suture only also has a very good survival rate in many studies. It's one of the studies you can see here. And we got another study here which compared again suture only and bone fixation regarding re-tear rates, failure rates, pain, and scoring system. It's about the same, no significant difference, okay? So basically for the fixation method, we have to decide on a case-by-case basis. For lateral meniscus, bone fixation is better. On medial side, suture only is as good as bone, clinically, okay? Rehabilitation, the goals are different, for people with minor or no chondral injuries or lesions, they're ideal patients. We want to get them back to sports, okay? So the goal of rehabilitation for them is quite different to people with severe chondral lesions, where they're salvage patients. For them, the goal is to get pain-free activities in daily living, okay? Spalding et al., who is the co-chair of IMREF, has done significant work on this. He's written a few chapters as well. So full rehab, again 3 phases for a isolated meniscal allograft transplantation. We got early restorative phase, conditioning phase, and functional rehab strengthening phase, okay? Outcomes, there are many studies compared medial and lateral. Both have shown good results. Some studies have shown medial is slightly better, but most studies have shown that lateral MAT is better than medial, okay? So this is another systematic review and meta-analysis. 4 studies have shown that they compared basically whether what are the differences if we do a MAT isolated or combined with any realignment or procedure along with any ligament deficiency where you can reconstruct it. 4 studies have shown that there is no difference. 3 of them have shown the results are inferior. In one study it has shown if you do a HTO at the same time if there is an indication, the results are better, okay? Again, another study by Parkinson et al. You can see the 5-year survival rate, 97% for partial, 82 going down, 62, depending on the extent of chondral loss, The lateral, again, MAT has significantly better results, okay? So again, another study regarding the progression of knee OA after MAT. You can see that if it's younger than 35, the survival is much better compared to older than 35, 24 to 8. In patients with no chondral damage, the survival is 43 compared to only 6.6 for a severe damage, okay? Again, another study, long-term follow-up of 72 MATs. Another study, you can see there, 230 minutes in military personnel. Okay. So he took the endpoint as when the personnel are discharged from military duties, okay, at mean follow-up of 2.5 years. Okay. So meniscal extrusion is quite common, either it can be minor or major, okay. But even though biomechanically it has shown it will happen, but clinically it has not shown to affect the results, okay. As I said, there are few systematic reviews on that, okay. So just a quick word about Tim Spalding. He was my consultant colleague in 2011 and 12 in University Hospital, Coventry and Warwick, as you can see in the aerial view there. There is a very big clinical trials unit there, okay. So he used to do along with Matt Coast and Pete Thompson, who was the clinical lead that time, okay. He has done more meniscal transplants than anyone in Europe and UK, okay, and also he's published extensively, okay. So he was my senior colleague there 2011 and 12, after which I relocated there. So he's also president of International ACL Study Group, co-lead of European Allograft Initiative and ICRS Foundation as well. He has published extensively, okay. So conclusion, new editions continue to be added, but the main thing, new thing is we can do it even with chondral loss, but we should explain the patient the inferior results and increased failure rate, okay. But apart from that, the indications have not changed, have remained the same more or less in the last 1 or 2 decades, okay. 3 modes of fixation, as I told you, suture and bone plug and keyhole, which are bony fixation, all are equally good, yeah. Biomechanically, even though bone is superior, but clinically the results are more or less the same for all the types of fixation, okay. So lateral mat has better clinical outcomes and lesser failure rate. It doesn't mean that medial is a failure. Medial also is quite good, as shown in a few long-term studies, okay. Ideal condition, we don't want any chondral lesion or a minor lesion, okay. That makes it ideal, and the chances of them returning back to sports is high, especially in young patients, okay. Meniscal extrusion is common, but it doesn't seem to affect the clinical results, okay. Thank you. Any questions?
Any questions?
There's not much on scaffolds and synthetic, yeah. There are a few studies just with year or 2 follow-up results. I think Sandeep is going to talk about them, yeah. But the most of the literature is on allografts, okay, where we have quite a few studies on long-term results with systematic reviews and meta-analysis as well on various aspects of the operation.
For India, do we have any meniscal allograft?
Yes, we have. Yeah, I think there are a few places. We have in MS Ramaya. I had one patient, but he backed off because of financial constraints. I think it's about 75,000, they told me. But presently it's unavailable. When I called them, it was available, but patient was not willing to spend.
Thank you, sir.
I think 75. 75. Yes. Yeah. Imported will be a lot more. Yes. Yeah, they are quite superior in terms of processing and how they're sterilized. Not sure. I am not sure if anyone has used them here. They're using. Yeah.
In India, are we really doing? Anybody's doing?
Yeah. So, Tim Spalding used to do them quite frequently when I was there. Yeah, I think he has over a few thousands he's done. I think he's published extensively along with Pete Thompson.
We'll go.
Yeah,
Thank you, sir. We'll go ahead with the next topic. Biological augmentation. That's by Dr. Raju Naidu, sir.
Facts and evidence. Biologics play a significant role in improving meniscal healing and outcomes. How biological augmentation help in meniscal repair? By stimulating cell activity, promoting matrix production, provide scaffold for tissue, inhibit proteases, cytokines which inhibit cell proliferation, sustain vascular ingrowth. The biological augmentations potentially reduce the need for revision surgery. Types of augmentation techniques: mechanical stimulation with rasping and trephination, venting, PRP, BMAC, fibrin clot, stem cell therapy, and biomaterials as scaffolds. Trephination is a straightforward technique. Spinal needle is arthroscopically used to drill holes in the red zone, creating multiple channels to divert blood flow from vascularized area to less vascularized area. This allows growth factors cells to reach the meniscal lesion, stimulating fibrous scar formation. It's further remodeling into fibrous cartilaginous tissues. The effectiveness of trephination is, as an isolated procedure, is still debatable. Abrasion or rasping. It is most commonly used technique. Abrasion of margins of meniscal lesion and the parameniscal synovium can be performed by using shaver or rasp. This is easy and fast mechanical stimulations, elicits a damage response with release of growth factors, cytokines that trigger the process of revascularization and healing. Excellent healing rates have been reported after abrasion combined with meniscal repair. Next is bone marrow venting. Significantly improved clinical outcomes and reduced reoperation rates as seen in meniscal repairs along with ACL reconstructions than isolated meniscal repairs. The biological healing factors are stimulated with bony tunnels drilling in the ACL reconstruction. This concept led to development of bone marrow stimulation as a method to augment meniscus healing in isolated repairs. Venting or microfractures of intercondylar notch with bone awl aims to stimulate the mechanism by creating multiple holes that penetrate the subchondral bone, release the marrow elements into the joint. Due to release of mesenchymal stromal cells and growth factors from bony tunnels, promote angiogenesis, matrix synthesis, cell proliferation. Kaminsky et al. Demonstrated 100% healing rates in 23 patients after meniscal repair with microfractures into the lateral aspect of intercondylar notch. PRP. This PRP has been used since 1970. Increased concentration of autologous growth factors thought to promote tissue growth. PRP can be used in single or multiple administration to the joint or directly inside the repaired meniscal lesion, and also used in biological support as scaffolds and clots. Platelet-derived growth factor is a major component in PRP to increase the soft tissue cell activity and stimulate repair. Puzzle and Kaminsky both are found good results in their studies. Griffin et al. Found no difference in clinical outcomes. Kaminsky et al. Demonstrated injecting PRP into the meniscal lesion after repair improves rate of healing, but multiple intra-articular injections of PRP do not appear to have any clinical or healing advance or its non-use. Platelet-rich plasma shows promised results but remains controversial due to the heterogeneity in the preparation of PRP methods and contribute to these consistent results. Further investigation need to roll off PRP in meniscal repair augmentation. Another technique is BMAC. Bone marrow aspirate concentrate augmentation in meniscus repairs involve injecting the concentrated bone marrow cells into the repair site during surgery. Bone marrow contains stem cells, hematopoietic cells, platelets, growth factors, cytokines that can promote tissue repair and regeneration. Bone marrow is usually obtained from the femoral notch or iliac crust by using trocar cannula. 3 to 5 ml of bone marrow aspirate concentrate can be separated from the 25 ml bone marrow aspirate after 15 minutes centrifuge. Patrick et al., Sentent, Kaminsky all have good results with BMAC after meniscal repair. Limitations of BMAC is BMAC has a low stem cell yield compared to cultures of stem cells. Heterogeneity in the preparation of BMAC and cell concentration. Lack of large-scale randomized clinical trials. It is added cost and technically demanding. And another technique is fibrin clot. Fibrin clot has similar healing component as PRP. Fibrin clot is readily available, easy to use, affordable and minimally invasive. Blood is taken from peripheral veins. Fibrin clot are prepared by intrinsic clotting process and stirring of patient's blood. Fibrin clots allow surgeons to more precisely localize the desired biological factor at the site of repair. Sutures should be placed but not tightened before the placement of fibrin clot. Harvest, formation, and preparation of clot should be happen concomitantly with the meniscal repair. Inside-out technique is easiest for placement of fibrin clot. Jung et al. Reported 95% success rate of the meniscal repair. Nakayama et al. Found 75% success rate in the degenerative meniscal repairs. Fibrin clot application is more technically demanding and invasive and time-consuming as compared to the simpler techniques such as rasping, trephination, and microfracture. The superiority of the fibrin clot or these techniques not being conclusively demonstrated. And another is stem cell therapy. Mesenchymal stem cells can be differentiated in vitro into various cells, including osteoblasts, chondrocytes, myocytes, and connective tissue. Stem cells can be harvested from bone marrow, synovium, muscle, and adipose tissue. Stem cells are potential source for regenerating connective tissue such as meniscus. Due to their enhanced proliferation, differentiation capabilities, synovium-derived stem cells are now favored over bone marrow and adipose tissue. In preclinical studies, animal models, so there is increased matrix deposition, high repair strength. In clinical studies, Whitehouse et al., Vaccines have good results. And the limitations for stem cell therapy, there is a lack of standardization in cell dose, source, and delivery method. High cost, limited large-scale randomized clinical trials with long-term outcomes, and there is regulatory issues with allogenic stem cell cultures. Early clinical studies are promising, but large-scale randomized trials with standardized protocols still needed to define. Lack of long-term functional and structural outcomes, it remains selective and experimental adjuvant. Conclusion, although several biological augmentation techniques have been introduced to improve meniscal healing rates, the overall quality of the evidence remains low. Mechanical stimulation has limited standalone value. PRP, BMAC, fibrin clot shows consistent results. Stem cell therapy appears to be promising, but still in preclinical and clinical studies going on. Preclinical studies of biological augmentation appears to improve meniscus healing, but clinical data remains sparse. Early clinical and preclinical studies are encouraging more quality long-term trials to be needed to standardize the protocol, confirm the efficacy, optimize the outcomes. At present, biological augmentation has not had predictable outcomes. Further research is required to establish their definitive role in meniscal repair. Thank you.
Thank you. Question to the audience, especially Khan sir and Praveen sir. For an isolated meniscal tear, only just a meniscal tear, if we are repairing it, are we regularly using any biologics? Or if we are using a biologics, what would be the ideal biologic?
So, for isolated meniscal repair, I use only marrow fracture, like trephining of the meniscus, that is one. Red zone we will stimulate through the spinal needle, and then microfracture on the intercondylar area.
You do all these, sir, or only?
Only two. Only two. One is a rasp, meniscal rasp. First,
that is a regularly we do
that
the
is,
meniscal rasp.
that is the freshening of the edges, trephining from the red zone with the spinal needle, and then microfracture on the intercondylar region. That's it. No fibrin clot, no PRP. No.
Yeah, that's what we are not using that. That's why I wanted to find out.
We are not getting any outside things into the inside. That's the thing.
Okay, sir. Thank you. So we'll go ahead with the next topic by Dr. Chiranjeevi, rehabilitation in meniscal tears, the aftercare.
Good evening, everybody. Myself, Dr. Chiranjeevi Varadu, Professor, GVP Medical College and Hospital. I would like to finish the topic very quickly. Okay. Thank you. So there is a lot of paucity with regarding the literature in rehabilitation in meniscus repairs. Unlike ACL, we have a lot of literature, but with rehabilitation in meniscal tears, lot of paucity is there. But I could find out one consensus, which is EU-US consensus, where they have given recent protocol regarding rehabilitation in meniscal injuries. So European Meniscus Consensus Project, where in the first part they have given regarding the degenerative meniscal lesions, where they have said partial meniscectomy has become not the first but the second line of treatment, whereas conservative treatment of the degenerative meniscal lesions is the treatment of choice. Whereas in the second part they have said that the preservation of meniscus including repair or partial meniscectomy should be the first treatment philosophy. Whereas the recently given consensus, which is EU-US Consensus Project, where they have given the usage of rehabilitation for patients with symptomatic meniscal injuries. So rehabilitation after partial meniscectomy. So what rehabilitation treatment is the best indicated for the management of patients with isolated partial meniscectomy? Is there any evidence-based protocol? There is no evidence-based protocol. Is there any difference between the rehabilitation between medial and lateral meniscus? There is no difference. Should non-weight bearing or partial weight bearing be recommended after arthroscopic partial meniscectomy? No. You should always give full weight bearing and full range of motion immediately after surgery. This is a grade A, high level of evidence. For how long the rehabilitation should be recommended in arthroscopic partial meniscectomy? It's around 4 to 12 weeks. Now coming to the meniscal repair, rehabilitation after meniscal repair. Is there any protocol? No, there is no protocol again, even for meniscal repair also. The earlier protocols were conservative with 6 weeks of immobilization and non-weight bearing for 2 to 6 weeks. But recently, accelerated protocols has been introduced wherein they have started giving immediate weight bearing for longitudinal or vertical tears, meniscal tears with repair. So here they use criteria based as well as time based protocol. How does location of the meniscus tear or repair influence the progression of rehabilitation after repair? For vertical or longitudinal tears, full weight bearing can be given immediately, as well as ROM can also be given immediately. But complex tears, horizontal tears and radial tears and root tears, you have to give limitation of weight bearing for 4 to 6 weeks. Are there any specific exercises that should be avoided after meniscal repair? Yes, deep squatting, jumping and rotatory movement should be avoided. But vertical longitudinal tears, the mini squats up to 30 degrees can be avoided for 4 to 8 weeks, up to 45 degrees for 8 to 12 weeks and up to 60 to 90 degrees for 13 to 16 weeks. Is there any difference between medial and lateral meniscus repairs? No. For how long rehabilitation is recommended for meniscal repair? For longitudinal tears, a minimum of 4 months, but complex tears like radial tears and root tears, it could be around 6 to 9 months. What are the criteria based recommendations? The criteria, they go through protective phase, restorative phase and return to activity or sports preparatory phases. From protective phase, if the patient should be moving to the restorative phase, they should achieve full passive range of motion. There should not be any effusion and they should gain neuromuscular control of the quadriceps. From the restorative phase, return to activity of sports, they should achieve full active range of motion, adequate single leg dynamic knee control. Again, the same thing has been shown in this table. Vertical or longitudinal tears, there is high level of evidence for giving full weight bearing immediately and the ROM also can be started immediately. But there is no conclusion between accelerated or conservative rehab as well as brace usage. In complex tears like complex oblique and radial tears, there are many systemic review. They have said all studies suggested at least 4 weeks of restricted weight bearing. Even the range of motion, there is highly variable variation in the studies. And the crutch and brace usage also, it's not conclusive. Root tears, most of the studies they have recommended non-weight bearing for 6 weeks. But range of motion, there is a lot of variation in between the studies. Some studies they have started post-op ROM immediately, whereas some they have restricted for 3 to 4 weeks. The brace usage also, there is no conclusion. Here in this table, again, you can see different meniscal tears depending on their complexity, the weight bearing, variation in the weight bearing and range of motion restriction. Now coming to the traumatic tears. By traumatic tears, what I mean is acute tears, rehabilitation management of non-operated traumatic tears. Does non-operative management benefit the treatment of traumatic meniscal tears? Many studies, there are not much studies in this topic, but few studies they have shown there is no much difference between rehabilitation and surgery. Evidence was published supporting the idea of self-healing potential, and the potential threshold of ramp lesion should be around more than 3 centimeters for repair. What rehabilitation interventions are best indicated for the management of non-operative traumatic meniscal tears? Specific interventions implemented to resolve knee fusion, reduce pain, restore quadriceps strength, and regain joint-specific motor control may be advantageous in traumatic meniscal tears. Rehabilitation management of non-operated degenerative meniscal tears. Again, as I have said, ESCA recommendation was non-operative treatment is the first line of treatment. And if there is no improvement of symptoms for 3 months, then you can go ahead with partial meniscectomy. And not all these degenerative meniscal lesions cause symptoms, but when they are symptomatic, the initial treatment should be non-operative. Is non-operative management as beneficial as arthroscopic partial meniscectomy for treating degenerative meniscal lesions? Degenerative meniscal lesions can be treated with comparable results with either non-operative or surgical approach. What rehabilitation is best indicated? Manual in degenerative meniscal lesions, non-operatively treated. Manual therapy, joint mobilization exercises, range of motion exercises, progressive knee and hip muscle strengthening, and neuromuscular training may be applied. Return to sports, again, return to sports was recommended as 4 to 12 weeks for partial meniscectomy and 6 to 9 months for meniscal repair. Prevention of meniscal injuries. There is no specific prevention techniques for meniscal injuries, but you have lower limb injury prevention programs like ACL, prevention injury and enhanced PEP, FIFA 11+, NAC control are few ACL injury prevention protocols. So this is the full ESCA protocol you can get. So thank you.
Thank you, Chiru sir. Next talk is by Karthik Paidi on the role of meniscectomy in 21st century.
Everyone. At the outset, I would like to thank the organizers for giving me the opportunity. Coming to my topic, I will be discussing the role of meniscectomy in the 21st century. To be precise, is there any role of meniscectomy? From once being labeled as functionless remain of leg muscle, the extensive scientific investigations has described the meniscus as one of the most crucial structures of the knee. As we all know, meniscus is a fibrocartilaginous structure that plays a vital role in joint stability, load transmission, shock absorption. Historically, meniscectomy, partial or total removal of the meniscus, was widely practiced for treating meniscal tears. However, accumulating evidence in the recent decades have reconsidered this approach. So, a lot of surgeons are moving towards meniscal preservation. So, there is a paradigm shift towards meniscal preservation. The key drivers for this meniscal preservation is the long-term studies of meniscectomy leading to cartilage degeneration and guidelines from the orthopedic societies promoting preservations. There is a lot of improving meniscal repair tools and techniques. Even now we are focusing mainly on meniscal repairs and better understanding of meniscal function. So there is an advancements in arthroscopic techniques, imaging modalities, and deeper understanding of the meniscus biomechanical role has led to a dramatic shift in surgical philosophy. So despite the shift, meniscectomy remains relevant in certain indications. Irreparable tears, complex tears, radial tears in avascular zones often cannot be repaired. And mechanical symptoms, persistent knee locking or catching, so often promotes for partial meniscectomy. Failed conservative or failed repair treatment, surgical removal of meniscus can be considered. And degenerative meniscal tears. So degenerative meniscal tears, common in middle-aged and older adults, are now often managed conservatively. Multiple randomized controlled trials, fidelity, finning degenerative, meniscal degenerative lesion trial studies, and meniscal tears in osteoarthritis research have shown that arthroscopic partial meniscectomy offers little long-term, it's not short-term, it's a little long-term benefit over physical therapy. And this is a good paper of 5-year follow-up, where arthroscopic partial meniscectomy for degenerative meniscal tears has shown that there is a little long-term effect, but there is short-term benefit is there. So arthroscopic partial meniscectomy offers short-term relief. Long-term results are concerning. The loss of meniscal tissues increases load on articular cartilage, which ultimately leads to accelerated osteoarthritis. And the knee alignment and gait can be affected, which alters the biomechanics. And there is functional decline, especially in athletes and active individuals. So for patients who have undergone partial meniscectomy or irreparable tears, there are emerging alternatives like meniscal scaffolds, biologic or synthetic implants for tissue regeneration. This will be dealt by the next speaker. And meniscal allograft transplantations in young patients to restore the knee function. And tissue engineering, ongoing research into stem cells and biological approaches to regenerate meniscal tissues. Next slide. Okay, fine. Next step. Stop shadows. Okay, fine. Leave it. So to conclude, meniscectomy remains a selective role. It is not a one-size solution. The future of the meniscal tissues mainly based on the advancements in the repair techniques and tools, and also the biologic and regenerative medicine. So, thank you.
Thank you, Gati. The next talk is by,
Just one observation about the...
My name is Dr. Sandeep. I thank SRS team for giving me an opportunity to present. Today I am going to talk about meniscal scaffolds and synthetic implants, what literature says. For a meniscal tear, there are a lot of treatment options available. If the tear is simple, we repair. If the tear is complex, we do meniscectomy. If there is complete loss of the meniscus, we do meniscal allograft transplantation. And if the patient is having degeneration of the cartilage, as well as loss of the meniscal tissue, if the patient is on a higher age side, then we plan for a partial knee or a total knee. Now, there are other treatment modalities like meniscal scaffolds and synthetic implants, which I am going to talk about. What is the clinical problem? After meniscectomy, what is the problem? Some patients, almost 25%, will have persistent knee pain and functional limitation. We call it as post-meniscectomy syndrome. Over 10 lakh arthroscopic meniscectomies per year were done globally. Meniscectomy leads to altered biomechanics and progressive degeneration of the cartilage. So our goal is to treat, preserve and restore the meniscal function. If we treat it, then the degenerative aspect will be decreased and we restore the knee joint biomechanics. What do you do for patients who have pain after meniscal surgery? Normally, after meniscectomy, the patient is having pain. We try to rehab the patient. We tell to decrease the weight and do activity modifications. If still pain persists, then we give intra-articular steroids or else hyaluronic acid injections. If the cartilage is damaged severely and the patient age is towards the higher side, then we do a replacement. There are some set of patients where they are too young for a replacement and too old for a allograft transplant, where these meniscal scaffolds come into play. These meniscal scaffolds and synthetic implants fill the treatment gap between the failed meniscectomy, those who are symptomatic, to that of those patients who are too old for the meniscal allograft or too young for a TKR. Coming to the meniscal scaffolds, these designed for partial defects. Here the prerequisite is that some part of the meniscus to be there, either an intact rim should be there or else the horns should be there for the meniscal scaffolds to be implanted. Then these are bioabsorbable scaffolds. The aim is to restore tissue volume, encourage native tissue ingrowth, and the delay degeneration of the cartilage. The ideal patients are less than 50 years. There should be an intact rim and meniscal roots. The advantages are that they maintain the original size and shape. They encourage biological integration. The disadvantage is that it is very limited data is available. What are the products available in the market? Coming to the meniscal scaffolds, there are two products. One is ActiFit and the other is the collagen meniscal implant. The ActiFit is provided by Ortec company, which is there in UK. The collagen meniscal implant, which is provided by the Stryker company. This collagen meniscal implant is found by type 1 collagen bovine Achilles tendon, where ActiFit is synthetic, which is formed by it is synthesis by polyurethane, which is biodegradable. Coming to the synthetic meniscal implant, which is called as new surface, it is found by polycarbonate urethane and circumferential polyethylene fibers, where it is completely synthetic implant, which is non-integrative in the body. Why these off-shell implants are important? Because these are readily available on the shelves, so we can use it whenever where we cannot repair, where there is an extensive defect in the meniscus, where there is no option for a meniscal allograft. These off-shelf implants play a crucial role. There is no need of any donor matching. They avoid autoimmune rejections in most of the cases. Uniform quality and sterility is maintained. These aim to support native tissue regeneration. Coming to the ActiFit, it is 80% porous, which is biodegradable, approved in European countries, not FDA approved yet. It is indicated for both partial meniscal defects, both medial and lateral side. This is the ActiFit implant, this is the ActiFit implant, where we can see the extensive porous coating. It's like a sponge where the bony, the soft tissue ingrowth happens, the vascularity develops. This is the arthroscopy image, where we can see the ActiFit scaffold has been implanted. This is the posterior horn. This is the prerequisite for for a scaffold to be implanted, because one part of the meniscus to be there, so that on top of that we reconstruct the ActiFold scaffold onto the meniscus. Coming to the clinical benefits, there is 81% tissue growth in 3 months. Clinical scores are significantly improved. 87% have survival rate of 5 years. The challenges are that there is scaffold shrinkage. Some may require conversion to TKR, or they need a meniscal allograft transplant. Coming to the collagen meniscal implant, this is made up of type 1 bovine collagen, promotes fibrocartilage, used for partial defects, both FDA and European country approved. This is the arthroscopic images, where we can see the complex tear of the meniscus. Here repair is not possible. So the defect was, the repair was removed, the meniscus which is damaged was removed, and a gauge was used to measure the defect, and it was replaced by a collagen meniscal implant, where after a redo arthroscope after an year, we can see the vascularity which is developed in the scaffold. The evidence says that there is 70% defect filling at 6 to 12 months. At 10 years, there is sustained benefit. It reduces, it does not reduce the joint space, as in meniscectomy, there is chances of reduction of the joint space, but in scaffolds, when we use, there is maintenance of joint space. On MRI, there is scaffold maturation and tissue integration. Also shows some shrinkage over time, but not linked with poorer outcomes. This is the synthetic meniscal implant. This is completely non-integrative implant in the body. It's like a free-floating device where no fixations are required. It is like an interpositional device where we just simply insert into the compartment where the meniscus is not there. It's directly a synthetic implant. It is indicated in 60 to 45 years of age, in between 60 to 45 years age. Those patients where there is near total medial meniscectomy was done, and those patients who are not candidates for meniscal allograft or arthroplasty. What are the advantages of this? Are that it is minimal invasive, fills the treatment gap, gives good clinical outcomes in older and higher BMI patients. The disadvantages are that there is high reoperation rates, requires technical precision, and long-term counterproductive effects are still under evaluation. This is the new surface implant, which contains ultra-high molecular weight polyethylene fibers to reinforce the polycarbonate urethane core. This is the surgical technique. First, initially, we'll prepare the joint arthroscopically. Then we remove the damaged meniscus, and we keep an intact rim of 2 mm periphery, so that the new surface implant which is there will get taken the shape of that condyle. This is the instrument where this is the instrument handle where to push the new surface implant into the side which is being operated. This is after preparation of the meniscus. There is an intact rim, 2 mm rim, to be there for the meniscal new surface to be implanted. This is after implantation. We can see the anterior horn of the new surface. Coming to the summary, Actifold and CMI are biodegradable implants. New surface is non-biodegradable. The indications for Actifit and CMR, it should be a partial defect, but new surface in a near total defect can be managed. The integration is good to moderate in meniscal scaffolds. There is no integration in new surface. The long-term results we have is that Actifold 5 years, where 87% survival. In CMI, it's 10 years follow-up, where there is positive data. And in new surface, it is still under trials. That too in it's undergoing trials. It's in 2 years. It's not yet approved. The counterproductive effect, Actifold is inconsistent. The CMI has some joint preservation. New surface relatively good, but it under trial. The reoperation rates for Actifold is around 70 to 38%. The CMI is 1 to 8%, and for new surface is 12% in the 1 year at first year, and 7.7% at 2 years. Coming to the literature, Vine et al. Concluded that scaffolds like Actifit and CMI are best for age less than 50 years and with partial defects and minimal OA. New surface is better for age groups between 40 to 65 years. This will bridge the gap between arthroplasty and meniscal allograft transplant. This is one more study which says the same, the Sun Group study, where new surface will bridge the gap between the meniscal transplantation and arthroplasty. This is one more study which says the same. This is Claudia and et al., where it is a recent study, 2022, where the scaffolds were used in younger patients where partial defects are there. This helped in biological ingrowth. New surface is for middle-aged synthetic option post-meniscectomy. All options show improvement long-term. Chondroprotective defect is unproven. This is a systemic review. The key objectives are the key objectives is to evaluate chondroprotective effect, clinical outcomes, and survivorship of meniscal scaffolds compared to meniscectomy versus each other. The clinical takeaway is that there is no superiority in chondroprotective effect for scaffolds over meniscectomy. Clinical scores improved after scaffold implantation, but not significantly better than meniscectomy. There is no significant difference between the CMI and the ActiFit scaffolds. Clinical take home is that less than 50 years, better to opt for these ActiFit or CMI scaffolds, which are biodegradable. And those patients who are middle-aged, 40 to 65, better to use a new surface PCU implant. Thank you. Sir, my questions regarding this, regarding these scaffolds. Any idea about these scaffolds? Not available, sir. But in UK and
of thanks, thank you.